College, Manipal. She is the honorary professor of bioethics in various universities in India. She was the head of the Manipal unit of the International Network of UNESCO Chair in Bioethics and the Indian program till 2020. In 2021, she was appointed as the head of Indian program of the International Chair in Bioethics. She has authored several papers in bioethics and moderated 44 webinars on ethical issues in COVID-19 pandemic organized by the Department of Education International Chair in Bioethics, Melbourne, Australia. She is a member of International Forum of Teachers in Bioethics and organizes, conducts, trains and teaches health professionals and students in bioethics. She received a distinguished leadership in bioethics education from the UNESCO Chair in Bioethics. She is a fellow in interprofessional ethics and fellow of the International Institute of Organizational Psychological Medicine. She is a co-editor of the journal Global Bioethics Inquiry, a scholarly publication of the UNESCO Chair, and a reviewer for various journals. I request ma'am to please start the session. Over to you, Marima.
Thank you, Dr. Indranil, and good morning to everyone. It's wonderful that we are at the day 4 of Ethos, correct, if I'm not mistaken. Today's session, it is just to, it's actually, it's not really much of, it's not really a big talk or anything like that, but it is something that I thought was interesting and that we all should be aware of. So just one moment. So the title of my talk today is Trust Me, I'm a Doctor, Busting the COVID-19 Myths. And as you all know, when this pandemic happened, there was a flurry and flood of myths regarding COVID-19 pandemic. And more than the pandemic, dealing with these myths were the problems actually for the healthcare workers and for the medical association. So what I'm going to do is just talk about a few of the myths that were circulating around. I'm sure there were hundreds and hundreds of them, but just a few of them. And I will end with what we should do as doctors to combat these myths regarding the COVID-19 pandemic. So the first myth that came up was, it was that COVID-19 is an airborne disease. Actually, it is not an airborne, but they call it as either droplet transmission or airborne transmission, not airborne disease. And any particle above 5 microns released either through coughing or sneezing can transmit the infected virus. And tiny particles less than 5 microns, just one more, please. Yeah, more than 5 microns are suspended in the air, and they can travel longer and for further distance. In fact, there is an article which has been put out by Lancet in 2021, April 15 this year, and it talks about the 10 scientific reasons to support in support of airborne transmission. So this was put out by the BBC to dispel all the myths regarding transmission of COVID-19. Then another, I'm sure many of you would have gone through these or received forwards regarding these myths. One of the myths that was circulating was a moist throat can ensure protection from coronavirus. Corona infection. So there is actually no scientific evidence to support this claim. But this was these were the articles that were circulating, and this was from Philippines, where someone called Sito was giving excellent advice, and it read like this: serious, excellent advice by Japanese doctors treating COVID-19 cases. Everyone should ensure your mouth and throat is moist, never dry. Take a few sips of water every 15 minutes at least. Why? Even if the virus gets into the mouth, drinking water or other liquids will wash them down through your esophagus and into the stomach. Once there in the tummy, your stomach acid will kill all the virus. And if you don't drink enough water more regularly, the virus can enter your windpipes and the lungs. That's very dangerous. Please send and share with family, friends, and everyone about this. Take care, everyone. May the world recover from coronavirus soon. May all be well and happy. Sito. So these were the things that were circulating, and this was what was, what people were reading regarding coronavirus. So another myth that was coming out was inhalation of steam water from inhaling steam from hot water, which kills the virus. In fact, if you see, there was a man in North India who was giving steam. I don't know how many of you have seen it. Steam as a treatment. You saw people lining up for the steam treatment, and actually it caused a spread of infection. So inhaling steam does not kill the coronavirus. Respiratory hygiene and social distancing and washing hands are effective measures to prevent COVID-19 pandemic. So before I move further, I just want to tell you much of my reference, and this is my disclosure, that much of my reference has been taken from my government website, our Indian website, and from WHO and other health organizations. So I don't want to make new myths, but I've taken them from reliable sources. Now, regarding this inhalation of steam from hot water, what happened was it did more harm than good. And there was a lot of cases of steam inhalation related scalds, and spillage of hot water was the most common cause, with 10 to 20% of burns in children. Requiring hospitalization and also scalding. And it took a minimum of 2 weeks for these burns to heal, and multiple trips to the doctors. Another myth that was circulating was sunlight can kill coronavirus. I'm sure we've heard all of this, but actually, according to WHO, there is no evidence to prove that sunlight kills the new coronavirus. And if you remember, we thought that, countries where the climate was very hot, the virus would never survive and no one would get the infection. But actually that was not true, because many of the countries, even in which were hot during summer, people were still getting the infection. And what it did actually was, if you look at this, this was put out as UNICEF, okay? And the symbol actually for UNICEF is not what you see here. So obviously it is a fake report. It says, if the virus is exposed to a temperature of 26 to 27 degrees, it will be killed, as it does not live in hot regions. Also, drinking hot water and sun exposure will do the trick, and staying away from ice cream and cold food is advised. So these were the things that were circulating. And what it did was, people were sitting out in the sun, and either you got a very good tan or you got sunburn. That is exactly what happened. Then this was a very interesting, a myth or a tweet that I found. So this was, it said, finally, an Indian student from Pondicherry University named Ramu found a home remedy cure for COVID-19, which is for the very first time accepted by WHO. He proved that by adding 1 tablespoon of black pepper powder and 2 tablespoons of honey and some ginger juice for half, which can be taken consecutively for 5 days, would suppress the effects of corona and eventually go away 100%. Entire world is starting to accept this remedy. Finally, a good news in 2020. Please circulate this information to all your family members and friends as received. Okay, so if this were to be true, then I'm sure half of most of Tamil Nadu wouldn't have got coronavirus, because there they do drink what is called as rasam, which is full of pepper. Okay, and I'm sure there were people who were actually drinking and a lot of rasam, thinking that it would kill the coronavirus. Okay, so the next one, this was also circulated. This was very, little. I mean, people can believe whatever you put out in the media. They'll believe anything uh, for a sense of false hope. Okay. So this one says good news. Wuhan's coronavirus can be cured by 1 bowl of freshly boiled garlic water. Old Chinese doctor has proven its efficacy. Many patients has also proven this to be effective. So 8 cloves of chopped garlic, add 7 cups of water and bring it to boil. Eat and drink the boiled garlic water overnight. Improvement and healing. Above all else, pray. Okay, maybe that would work. Okay, so this was what came out regarding garlic. This is another one which says in breakfast, take garlic extract. So how do you take the garlic extract? 2 peeled garlic cloves, cut it little pieces. You may use tool. So they've given you the diagram of the masher. So you can use that. So mash it, add 2 spoons of water, add 2 spoons of olive oil, mix it, pass through a mesh and put it on toast. Okay, so you can also eat this. And garlic, if you know, a lot of people believe in garlic. It does have antimicrobial properties, but not to the extent that people think that's going to kill coronavirus. So WHO had put this out saying that garlic is a healthy food that may have some antimicrobial properties. However, there is no evidence from current outbreak that eating garlic has protected people from the new coronavirus. Okay. Next one, heavy intake of vitamin C can help in curing corona infection. Okay, so regular intake of vitamin C boosts immunity. However, excessive intake is not recommended. And this is what was put out by the MyGov app, MyGov website. What happened was suddenly the market was flooded with vitamin C, strips of 500 milligram of vitamin C. If you wanted another packet of cumin to be added, then that was also there for 250 milligram, and vitamin D, 1,000 international units. All this was happening. The price just soared, and all at the end of it, what did you get? In a very expensive vitamin C enriched urine. So that is what was happening. Another one which I think majority of us would have at least tried it, because this was also circulating in my department. Lemon and turmeric prevents COVID-19. So everybody had recipes. In fact, it was forwarded on our department group. Please, all of you try this, it works. So there is no scientific evidence that consuming lemon turmeric can help prevent COVID-19. However, it is recommended to consume adequate fruits and vegetables as part of a healthy diet. Another one, the virus survives for a few hours. So actually that people were, thinking, oh, it is a very fragile virus. It will just die if it is outside, but it is not. This was put out saying studies suggest a coronavirus may persist on the surface for a few hours or up to several days. This may vary under different conditions. Example, a type of surface, temperature, or humidity of the environment. Another one, this is the one that actually drove people into a frenzy of buying antibiotics. It said, antibiotics effective in preventing and treating the new coronavirus. So what happened was the pharmacy, if you went to the pharmacy at that time, you would never get antibiotic. In fact, I should be honest, I also bought a few antibiotics and kept, but that is not because of this. I was worried about the lockdown. So if anything happens, if I don't get, but then by the time you went to get it, it was already sold out in the pharmacy. So Indian government made a rule that if you want to buy antibiotics, you should have a prescription. Okay, so no antibiotics do not work against viruses, or it works only against bacteria. The new coronavirus is a virus, and therefore antibiotics should not be used. However, if you are hospitalized for the coronavirus, you may receive antibiotics since bacterial co-infection is possible. Now look at this. this was the price of all the antibiotics and the antipyretics. So paracetamol, azithromycin, ivermectin, all this was touted to be treatments for coronavirus. Doxycycline. The price of this just went through the roof. It rose by 180% in 4 months. It was, and of course, it was there in the black market also. If you want it, you can buy it in the black market. Some of it was fake medicines too. So we really don't know if it was actually paracetamol or not. But then when you go to the pharmacy, you couldn't get paracetamol without a prescription. So that is what happened. Then mosquito bites get one infected with COVID. So this was also spreading, saying that mosquitoes transmission of coronavirus is through mosquito bites. So COVID-19 does not spread from mosquito bite, but through droplet spread when an infected person sneezes. This one came out, okay, this was put out by, to bust the myth of eating chicken can spread the new coronavirus. So this was put out by the WHO, Southeast Asia. To counter that, they said the fact is that eating hygienely and prepared and well-cooked chicken is safe and does not cause the spread of new coronavirus. So you name it, actually every possible food myth was there during the COVID pandemic. Now look at this. Eating ice cream can spread the coronavirus. Okay, another fruit, a mango also. So the price of mango just went, you couldn't get mangoes also. So mango cures the new coronavirus as the acid in the fruit kills it. So WHO has put it out saying there is no scientific evidence that mango kills new coronavirus. Another one is this durian fruit. I don't know how many of you know about this fruit. You get it in Malaysia. It's very popular. You can eat it, but because of its smell, a lot of people don't like it. But actually, it's very tasty. So durian, the price of durian in Malaysia also went through the roof because someone said it has protective effects. Another myth. This was actually quite dangerous because it said that the incubation period was only up to 5 days. So people thought when you're exposed to the virus, after 5 days, if you don't get any signs or symptoms, then you do not have the infection. So the incubation period means the time between catching virus and beginning of symptoms. Most estimates of the incubation period for COVID-19 is actually ranging from 1 to 14 days. So you still have to be careful. Now another myth, okay, this is regarding the sanitizers. Alcohol-based hand sanitizers increase alcohol levels in the blood. So according to WHO, alcohol found in the blood after use of sanitizers is negligible, and actually you don't become an alcoholic using these alcohol-based sanitizers. So another one is our hand, and of course, what happened was the price of, I think many of you know that hand sanitizers you couldn't actually buy in the supermarkets. It was all sold out. This myth was regarding our hand sanitizers, the only solution to protect oneself from COVID-19. So people thought, this is the miracle, the cure for coronavirus. And actually what happened is we had installed a lot of hand sanitizers in our department and in the floor of our building. Everything got stolen. Okay, so people were stealing left and right. So finally they had to fix a box, fix it, nail it onto the walls so that it would not get stolen. And in fact, there was some, they made special boxes with the lock and key where you can use the sanitizers only based on if there is a sensor, it will sense your temperature, and then the drop of fluid will come down. So that is what has happened here in my department. But no, practicing frequent hand washing with soap and water is enough to stay protected from COVID-19. However, if you don't have the facilities of washing your hands with soap and water, use an alcohol-based hand sanitizers. Okay. In fact, I think everybody started hanging hand sanitizers, at least the ladies. There was an attachment with their handbag where you attach, or phones where you have a small hand sanitizer, which is maybe good, yes. But then the poor people who can't afford, they think this is it, this, they have it and we don't. So actually just telling them that just wash your hands frequently, don't touch your face and mouth, that is more than enough. In fact, I think one of our talks, webinars, we did say that, there was an interview of a mother. She said, I don't have money. Do I use the money to buy sanitizers, or do I use the money to buy food? So people were in a very pathetic situation during the lockdown and during, that is 2020. Another one, this is what is circulating now. We are fighting a battle against vaccination. We have a lot of anti-vaxxers who are spreading a lot of misinformation, disinformation. So just to tell you about misinformation is giving wrong information. But disinformation, when you use that word, it is information which is meant to deceive. Okay, so both are dangerous. Disinformation, of course, is even more dangerous. Now, we have got through the crisis of the disease as such, have fairly good control. But now the problem is regarding vaccination, to take or not to take. Okay. Now, those who have taken, and this I think is also people in the health profession, they feel that after they get vaccinated, there's no need to follow COVID protocol. So the mask comes out, we lose our guard, and then that is how the infection is also spreading. In fact, I had to tell a doctor friend of mine, she was more concerned, how long do we keep wearing these masks? I'm vaccinated anyway, so why should I wear a mask? See, if doctors can think like this, imagine what a common lay person will think. I had to tell my maid, she got both her vaccination, both her doses, and she wanted to take off a mask. I said, no, you will not take it off. You will still continue to wear a mask, because there's still a chance. So she said, then why did I take the vaccine? So you have to explain to them what is the need for the vaccine and what it does, that you're not actually free of the disease, but in case you do get the infection, it will be milder. So this is another one, you don't need vaccine after recovering from COVID-19. So in fact, the recommendation is that complete the vaccine schedule irrespective of the past history and infection, because this will help in developing a strong immune response against the disease. Now, this was very funny and hilarious, but it was circulating where people said that those who have 5G mobile networks, they are the ones who are getting the virus. But then, of course, this is put out by WHO. It said that viruses cannot travel on radio waves mobile networks. COVID-19 is spreading in many countries that do not have the 5G mobile network. So it's nothing to do with the mobile network. It spreads through respiratory droplets when an infected person coughs, sneezes, or speaks. Okay. So what is our role now as a physician? So many myths, so many wrong information. This is a new role that we have to take on as mythbusters. It is important that we still remain as ambassadors for health. Especially now it is the vaccination phase, so we should be vaccine ambassadors. We have to tell our patients, encourage them, and answer their questions. They're also confused because media tells something, social media says another thing, newspaper says something, television says something else. So where do they go with so much of information? Then they Google and they find their own, all these things that are these myths that are present in social media. So you should talk to them and stop this anti-vaccine rhetoric where people keep saying, no, I don't need vaccine, I'm this and that, and herd immunity. A lot of things are coming up, of any small reason for not to be vaccinated. Okay, so it's important that we still maintain the trust, which is the heart of the patient-physician relationship. You have to talk to them. You have to tell them the need we have to spend time regarding this. So what are the countermeasures that we can take as doctors? We have to address these fake news that is there in social media, the news channels, newspapers, and especially when there is misinformation and disinformation. And do not forward messages without checking fact. Many times we do it as just, we get it, we send it. Turmeric cures, okay, let me send it to my group, my school group, my MBBS group, whichever group I am in, forward it, But no, as doctors, we do have a responsibility. We have to be responsible. So check the facts and don't forward messages lightly. Then provide videos, pamphlets, and literature. This is very important. If because I did see a few doctors that put out videos to educate the public. See, that is the way you can have counter measures for these kind of myths, or distribute pamphlets, give them literature. So if you are a private practitioner, or even if you're an intern, if you're sitting there, if you have a few pamphlets, you don't need to make them hi-fi. You can also draw diagrammatically represent what you need to convey, especially children. Children always look at pictures, and if you want to explain something, you can draw it out for them and tell them. So that is very important. So you can make your own videos and circulate it to combat all this fake news. For those patients who are who like to Google, you should direct them to reliable sites where they can get good information. And when we are talking to patients, we should use simple language, not these complicated terminologies that they can't understand. So that is very important. And one thing good about certain countries such as Australia, I was speaking to Dr. Russell, they have strict punishment fines for those who spread misinformation. So that is very important, because if the government is also responsible, they can take action this way and stop all misinformation that is there in the media. Okay, now this was, I'm sure many of you heard of Baba Ramdev. This created a lot of controversies and fights. The Patanjali, he put out the cure for coronavirus, saying that Patanjali has a cure and came as a kit. It was called a coronal kit. And fortunately for us, the Indian Medical Association, IMA, came out and filed a 1,000 crore defamation notice to Baba Ramdev for spreading this misinformation and disinformation. So this is where active, when you're part of a association, you can take active role in this, because you can't be quiet listeners and we are not passers by just listening to all these wrong information that is being there projected in the news media. See, these are helpful pamphlets where you can just keep it. Children can look at it and say, how does COVID-19 virus spread? Do this to protect yourself and others. Children can just look at it. Oh, there is a diagram. Two people should be 1 meter apart. What all can I do? I should not touch my face. I should wash my hands, use a sanitizer. All that, the pictorial representation is very good for these kind of to teach the common people. See, this was another one where the pregnant women didn't know whether they had to breastfeed. Will the virus be transmitted through breastfeeding? So the CDC put out this pamphlets showing what should be done in case a mother has COVID-19 and she wants to breastfeed. So these are helpful information that you can put out. So this is what we actually should be doing. Now, educating patients is not the only thing. You also have to educate physicians. We need to be updated. So either we host webinars where we call people who are subject experts, or attend webinars or talks to keep updated. And we have to read the latest literature. And when I say latest literature, I say it with a pinch of salt, because there were many articles that came out I'm sure many of you know about the chloroquine fiasco, the number of publications that came out in prestigious journals such as Lancet, and then they had to retract it because it was actually not true. And while I was preparing this, I was just amazed that the government of India had put out a lot of information regarding this, but none of us knew it. That means it was not projected well. So actually, they should be going onto the media and social media and the news channels to say, to put out all the information that they had instead of putting it only in the website. Because how will the common man know about what is right and what is wrong? So AMA, that is American Medical Association, had a series for their physicians, and this is the way we should go. It was called the COVID-19 series, what a physician needs to know. So they brought in experts to talk about about various aspects of COVID-19. Now, I think many of you are part of our International Chair in Bioethics. We decided that we will have multiple webinars during even when the lockdown happened. So our first webinar was around March, April, when we started the series, and now the Department of Education of the International Chair in Bioethics, which is formerly the UNESCO chair, we have hosted 51 webinars on this COVID-19 pandemic. The main reason being that we wanted everyone to be informed, to be updated with what is happening, to know what is happening around the world, and of course the quest of solidarity, to keep us all together, that we are all in this together, and to give each other hope in this difficult time, right? So we don't need we just have to do our professions and do our work professionally, and even superheroes will bow to doctors. So with that, I thank you, and I will stop sharing my screen. Thank you very much.
Thank you so much, ma'am. Any question from the audience?
I'm sure all of you would have had some sort of experience regarding all this myths. I'm sure different countries had different types. In India, we had a lot of food myths. That is, eat this, eat that, don't eat this, But I'm sure it was there in many other countries too. So, yeah, this is where we have to be very careful. As doctors, we have to play an important role. We can't sit back and keep quiet and watch all. Yeah, I think Emmanuel has raised his hand. He wanted to say something. You can unmute, I think. I think the organizers.
Hello.
Yeah.
It's a morning here in Uganda.
Okay. Good morning.
Good morning. This is Mujuni Emmanuel. I'm a second-year student, bachelor's in medicine and surgery from Makerere University. So I enjoyed the talk. I enjoyed the talk because some of the myths you talked about were shared here in Uganda.
Okay.
People didn't know what to eat. They were eating garlic, eating a mixture of things, some leading to ulcers. So there was really nothing. There was really confusion on what to do and how to do it. Maybe one of the myths I would like to talk about is that, alcohol-based sanitizers are made of alcohol.
Alcohol,
so some of the people started taking alcohol.
Yes.
Claiming that taking a lot of alcohol would kill the virus in the body.
Yes, it was a convenient excuse to drink alcohol.
Yeah, that's what was happening around, but it was later cleared by the medical authorities. Thank you. I enjoyed your talk.
Thank you, man. Thank you so much.
Thank you, Mojuni. Thank you so much, ma'am, for such an interesting session. And thank you very much for taking time from your busy schedule.
Thank you very much.
Thank you, ma'am.
Excellent talk, Dr. Mary. Really enjoyed it.
Thank you, Derek.
It was a good reminder of what we went through, like
I'm sure
Is
you
that
would
so?
have. I'm sure you would have taken garlic and lemon, Derek.
No, and lots of haldi milk.
Haldi milk, yes,
That's
that's
what they
true.
said.
Turmeric.
Everyone drank haldi milk till their whole body turned yellow,
Yes.
and then they didn't know what to do. So,
Yeah.
but anyway, difficult
Thank
times and challenge. Thank you for clearing all that up
Yeah.
for us.
Thank you, Derek.
Good afternoon, Dr. Russell.
Oh, sorry. Good afternoon, Derek. Good afternoon here. Good to see you all.
Hello, everyone. Now we will be having another great session on narrative inquiry, a powerful tool in the bioethics healthcare education. I would like to invite our speaker, respected Dr. Derek D'Souza, sir. Dr. Derek D'Souza, sir, is the head, Training Indian Program, International Chair in Bioethics, formerly UNESCO Chair in Bioethics, Haifa. I request Dr. Derek, sir, to please start the session. Over to you, Dr. Derek, sir.
Thank you, Dr. Indranil. I hope I'm audible.
Yes, sir. Yes.
Yeah, thank you. I'll just share my screen. Okay. I hope that's visible right now.
No, sir.
We can see the fireplace.
Yeah,
Yes,
it's
that's
visible.
it.
Yes.
Yeah, I can see it.
Okay, okay.
Yeah.
I think Dr. Russell, your mic is on.
No, not Dr. Russell. I think somebody else's. I don't know whether it is DigiShield.
DigiShield, please mute yourself.
Okay. May I start?
Yes, sir.
Okay. I'll go back to my full screen later. And just a disclaimer that if you don't find the slides changing, don't worry. I just want to share a story or two with you all. So just need your attention, and the slides will not change for some time. Sarah and Rebecca were as close as sisters could be. They were close in age, in their late 20s, with Rebecca being older by 2 years. The tragedy occurred on a Wednesday. The sisters had not met for dinner, and according to their routine, Rebecca telephoned Sarah at around 7 p.m. After 4 rings, Sarah's answering machine was activated on her landline. A few moments later, Rebecca's call to Sarah's mobile phone went to voicemail. Rebecca waited approximately 10 minutes. Perhaps her sister was in the shower, but later on again reached only message systems on both telephones. Rebecca rushed to her sister's apartments, ran up 4 flights of stairs, and despite loud knocking, received no response. Luckily, she had a key and let herself in while calling Sarah's name. Lights on, briefcase on the table, jacket on the back of the chair, and Sarah lying on the floor, unconscious. Rebecca dropped to Sarah's side, dialing 911 as she desperately searched for a pulse. Only later would Rebecca learn that Sarah probably had lost consciousness after a sudden cardiac arrhythmia. The emergency medical squad had arrived within minutes and started CPR. In the hospital's emergency department, Sarah was immediately placed on a ventilator. How long had she been down? How much time had passed since she had taken a breath on her own? How many minutes had gone by without oxygen to her brain? No one had any answers. After 2 weeks in an intensive care unit, Sarah remained unresponsive even to what doctors described as painful stimuli, such as rubbing Sarah's sternum bone. High doses of medications were initially needed to maintain her blood pressure. A tracheostomy was performed to protect her vocal cords from being damaged by the endotracheal tube, but she remained ventilator dependent at high oxygen settings. A few of the nurses had begun to talk openly about the likelihood of severe brain damage, and Rebecca overheard a doctor say that the patient might be trending towards brain death. Rebecca and her father consulted their rabbi. He counseled that because Sarah was still breathing, her heart beating, she was very much alive and must be treated as such. The rabbi strongly recommended that Sarah be transferred to a specialty hospital given the absence of signs of improvement, and he offered to use some of his contacts to help make this happen. Rebecca and her father agreed with this recommendation and initiated the transfer process. Let's go ahead. My father knew, but at age 13, I didn't, that the original decision for me to grow up as a boy had been made in a somewhat haphazard way. I had entered the hospital at the age of 6 weeks with a girl name to be evaluated for female appearing but slightly masculinized genitalia. I went home with a boy name, a diagnosis of male pseudo-hermaphroditism, and instructions to my patients about how I would eventually have some kind of masculinization surgery. Things got a little more complicated a little over a year later when I was actually seen by a plastic surgeon. I was too close to the female end of the anatomy spectrum for masculinizing surgery and to have much benefit, practically or cosmetically. This led to a re-evaluation of my sex of living. It isn't clear how this new decision was made, but I remained a boy, although any sort of surgery was projected into the indefinite future. The story I got as I was growing up was that some kind of surgery would happen when I was older. The specific age I picked up was about 18 years, which was about twice the age I was when I first heard this. What the pediatric endocrinologist wrote in those enigmatic notes must have been based mainly on a single office visit I had with him about 6 months earlier. I remember being very confused and upset by what I overheard during the long conversation my father had with the specialist. Although I remember a little bit of the content very clearly, I did pick up on various ideas that the doctors had determined that I was a boy, that genuinely changing sex was impossible. Sometimes children like this did not even go to school, but were kept at home. He also said, "We doctors don't want you to be embarrassed," which hoped that I would be excused from having to undress for gym class. He was actually referring to the mastectomy he had been planning since I was an infant. Afterwards, I was alone with the endocrinologist for a very brief talk, consisting mainly of a point-blank question whether I would want to be made into a girl. Once I replied with no, which I thought was the expected answer, this conversation was immediately over. The rest of the appointment considered of me being asked to pose for photographs, to show other doctors so they can help me. I remember wondering when I would find out what those other doctors had to say after viewing the photos. So, a very good morning, ladies and gentlemen. Thank you and welcome to this short introduction of narrative inquiry, a powerful tool in bioethics healthcare education. As you all saw, these were two very different stories. Of course, I read it out only in part in the interest of time, but it just gives you an insight into what it is like for a patient who is currently diagnosed as intersex, that is neither male nor female, and also what a family goes through, the trauma, when a personal relative, a friend, someone that you are close to, lies in the ICU, hooked up to a ventilator, and is given a diagnosis of what we call brain dead. So, what exactly is narrative inquiry? Well, this uses stories, letters, conversations, interviews, family stories, photographs, maybe even our own life experience, as a means to research, to understand the way people create meaning in their lives. Now, it does not only focus on an individual experience, but it gives you the larger picture, as we saw. It is the social, the cultural, the institutional narrative, which all help us understand how those experiences are shaped or expressed or enacted. So, what we would like to do today is understand what is meant by this narrative inquiry and see how we can use it as a tool in bioethics education to change the way that we communicate and to improve the core competencies of residents. It's a nice thing if we can incorporate narrative medicine as a teaching method to promote this core competency, because our residents are able to respond and recognize these bioethical issues or bioethical dilemmas where they are about to arise and prepare themselves, the patients and the patient's family, accordingly. If we incorporate such personal narratives into the clinics, it will narrow the gap of the way clinical medicine is currently practiced and the young caregivers of the future. Not only, it will make our future doctors as better providers of care, which is the goal of all of us. So, is there a need Now, today, the main objective of medical education is to instill a professional attitude, skills, and values in the physicians of tomorrow. There is also an idea or a background that we want to develop a very holistic approach to patient care, to build up a new generation of clinicians who are competent to meet the challenges of clinical practice. Practically, what happens is that the second goal gets lost while trying to fulfill the former. In recent years, this scenario has worsened. Why? Because of technological advances in medicine. This has made medicine to be very technical, to be very oriented on tests, on investigations, on robotic surgery, on machine learning, on artificial intelligence. But the human being is gradually being removed from this equation. And as a result, there is loss of individuality. You become just a number in the system. You become a card which carries all your information, which can easily be sent around. You don't even need to move. The clinician will tell you very confidently, I've shared your records with N number of people all over the world, and they will give me back their responses. They will give me back their inputs. The result of all of this is that there is a huge gap, not just physically, but even in the trust between the physician and the patient. Nowadays, illness is not just looked at a simple disease or what we call a pathophysiologic event, but rather it is seen in the more holistic way of having a personal, emotional, and relational components. So until all of these are considered together, they are considered in a very holistic manner. Remember, we are always treating a human being. We're treating a father, a mother, a daughter, a sister, a grandparent, or maybe just a friend. It is not like we commonly just say, oh, that is a gallbladder, or that is a third molar surgery, or that patient has come in for rehabilitation. They have names, they have an identity in society, and we need to remember that. Today, there is a dire need that medical schools need to expand their curriculum by integrating medical humanities, psychological, and social dimensions along with the biologic dimension. So as we understand the disease process, as we understand the various treatments that are available, also it is important to stress upon the relationship between the caregiver and the patient and understand the huge benefit or the therapeutic significance of this relationship. And of course, I'm very glad that we have under the Department of Education of the International Chair in Bioethics, or formerly the UNESCO Chair, to have this wonderful goal or to have this wonderful program that is all over the world, where we have been able to integrate these principles of bioethics as were laid down in the Universal Declaration, of integrating them into the daily curriculum. So whether it's basic studies in anatomy, your preclinical, paraclinical, or as you grow up into your clinical specialties, the principles of medical ethics, the principle of improving your level of care has been beautifully integrated, and we are seeing a lot of positive outcomes from this alone. So we have the ability to acknowledge, to absorb, to interpret, and even act on such stories and hearing the situation or the experience of others. So along with your scientific ability, along with your ability to read an X-ray or to read an ECG, to be able to correctly prescribe or outline a line of treatment, it is important that physicians listen to the narratives of the patient. And when I say narrative, it does not mean just a clinical history like we would normally record. So that is very cut and dry. That just highlights the important points which the clinician would need to diagnose or to record to treat the case. But when a patient tells a story, or when the patient is encouraged to tell his story, we start to look at them as a human being. We start to understand their role in the society. What does it mean if they are in the hospital? How does that affect the family at home? How does it affect the children who have to go to school, or the husband who's a daily wage earner? So the treatment that we have prescribed has to be tailor-made in the light of the social situation of the patient as well. So this can be accomplished by reading more or by reflective writing. And this whole concept or this whole procedure or this whole process is what we understand as narrative medicine. So here, narrative medicine, it addresses the therapeutic benefits that can derive from both patients and providers forming and telling their personal stories. So remember, it's not just hearing from the patients, but also from the healthcare providers, because remember, they are tightly bound in this relationship with each other. You cannot separate one from the other. Both are integrated. Both must live and grow and flourish together. So this offers a very innovative model for improving healthcare outcomes. It has a positive benefit on both sides. It has a way of conveying emotions. It has a way of conveying a better outlook for both patient as well as the healthcare provider. So what does it do? As clinicians, it allows us to practice our clinical medicine with greater skill, with empathy, which is something that is very difficult to really teach until it is demonstrated, to have a chance to reflect, to bring out true professionalism, and again, to restore this trust that has broken down, to restore this relationship that is on the verge of breaking. We've seen all over the world that because of this lack of trust, that is one of the reasons that there is a breakdown of traditional medicine. There is a lot of violence against doctors. There is disbelief in even published journals. And we heard from Professor Mary Matthew in your previous session, I don't know how many of you were there, about so many myths floating around. Everyone would quote WhatsApp University and claim to know the best. And the sad part is when a patient starts to believe his mobile phone more rather than the clinician that he would go to. So what are some of the situations into which narrative medicine can fit? One is between the physician and the patient, the physician and himself, physician and his colleagues, physician and the society at large, and the physician and his or her family. Now, like I already said, by exchanging stories, by the physician being able to interact with the patient, tell him how the healthcare provider himself feels concerned, how he is worried, how the whole team is worried about the well-being of the patient. That allows the patient to understand how much care is actually being given. A physician and self would like to write down, maybe at the end of the day or end of the week, a few notes to himself of how he was under stress, of how he was able to overcome the stress, or how a particular patient was challenging, And when he was able to make a correct diagnosis or a difficult surgery, and at the end, you had a patient who recovered, how much satisfaction and how much happiness that brought. So when you read that, it's like a self-affirmation and can do wonderful to your own professional behavior, encourage your feelings of empathy, and make you a better human. All these also have a very important role of reducing physician burnout. Today, we know that physicians and healthcare providers are under the greatest stress from all sides, whether I'm sorry, it is their colleagues, it is the system, it is the patients, it is the relatives, and even from their own family. So the roles that we play with our colleagues in society as being a member of society, and again, like I said, of the family. So when the physician can come back and share his stories without, of course, breaking patient confidentiality, the family is able to understand why their father or why their mother had to be in the hospital for late hours, or what was the benefit that they were able to provide to some other family or to some other individual. So that not only reduces the stresses in the family, they become more supportive. They become more understanding of the overall situation. Not only that, it also helps us to address the core competencies of what we want to improve in our residents of today, that is the specialists of tomorrow. So how does this help? When the physician and the patient, himself and the family, all of them come together, and with the background of narrative medicine, it will improve patient care. Between the physician himself and the patient, when they have to share knowledge, the physician or the healthcare provider has to strengthen his knowledge. He has to be able to explain to the patient why they are doing a particular treatment outcome, why they are trying out a particular medication. So it improves the medical knowledge. When you talk to your colleagues and society, it improves overall practice-based learning as well as improvement of general healthcare providers. Like I've already told you, when it becomes a chance for the physician to interact with his family, that will reduce his stress because he's able to share his stories. He's able to share his day at work, how thoughts of the patient welfare were in his mind, how he was able to benefit someone. And at the end of the day, this prevents burnout and improves the outcome for everyone. So in all situations, empowering ourselves through narrative medicine, not only does it improve our interpersonal and communication skills, but makes us a better professional. And that is ultimately our goal. Does it help in healing? Definitely. When we talk about wisdom, so wisdom is something more than knowledge. So we need wisdom regarding just medical knowledge? No. Patient care, communication, professionalism, practice-based learning, and ultimately having a good system-based practice for the entire gamut of healthcare providers to come together and work in the right environment. So how does it help in healing? For a patient, it gives him a coping strategy. It facilitates adjustment and adaptation to his new situation. If he is being kept in the ICU, or if he is recuperating even at home, but unable to move around, unable to assume his normal duties, all that will help him to cope better. It helps him to process his own feelings, his reactions, maybe feelings of disappointment, maybe he may be depressed, and that will help us to understand and get him the right treatment. Encourage his capacity to express and communicate openly, again, it builds up trust. And overall, we've seen that this, because of the holistic nature that we understand, it will promote healing and give us improved health outcomes at the end of the day. For us as healthcare providers, it helps us to process our reactions to different situations, to grief, to being involved with the patient and sometimes unable to understand how to deal with a situation. And overall, yes, it does help as protection against burnout. So, with that, please accept my best wishes on this new journey of narrative inquiry. Please incorporate it into your practice, incorporate it into everything that you do, because it's a wonderful way. I think each one of you would have enjoyed the story when I started out. It's a new way of thinking. It's a new way of sharing knowledge and something that can help us all in the future. Thank you.
Excuse me.
Yes, Dr.
Dr. do you read novels? So you're not audible.
Yes, I'm sorry, Dr. Indra. Tell me.
Sir, do you read novels?
Do I read novels?
Yes.
Unfortunately, no, of late. But yes, I've read a lot of novels. And for me, even creative writing, that is extremely close at heart.
So have you read, I'll name you 3 books. I want to know if you have read any of these.
Yes.
Frankenstein, Dracula, and Dr. Jekyll and Mr. Hyde.
I've not read the full novel, let me be frank, but I have read abridged versions of all 3, yes.
So if you notice, all of these 3 novels employ the use of epistolary style of storytelling, in which the narrator doesn't simply tell the story, it is in the form of letters. Each chapter is a letter between 2 people, and we have to figure out the story from those letters.
Yes.
So is this a way of storytelling similar to what you were suggesting, narrative teaching?
Yes, of course. Like I said, it is a holistic way which includes stories, experiences, photographs, anything it could be for that matter. Because maybe when your patient comes, or if they are in the ICU for a long time, and you find someone comes to visit. So you can always ask that person that who is this child who has come, or who is this person who has come to visit you? And when you come there and you start to inquire, you start to understand the larger context of the family. So you understand that, okay, this is not just a patient anymore, but he or she has a family to support them. So maybe there are grandchildren who are allowed to see the aged patient in the ICU. I'm sorry. And maybe one of them is appearing for an exam, or maybe one of them is not too well themselves. So by you initiating a conversation with your patient, apart from the normal, hi, how are you doing better, do you having any pain? When you start to ask that patient, how is your grandchild doing? You must be worried about the exam. You must be wanting to go home and be with them. You know their exams are coming up. Or maybe they're having some issues themselves. So one is you are diverting your patient from thinking about his or her own illness, his or her situation, going into depression, being in a hospital, being in a medical setup. You allow them a chance to think differently. You give them a chance to understand that, yes, you do care. And if it has to be done with a very genuine intent. You can't ask a question and keep looking at the medical chart or thinking of something else. So it has to be done with empathy. It has to be done in a very genuine manner. And this, if we go back and see, was where we have lost out. The family physician or the doctor would be invited to all the family events, whether it was the birth of a child, whether it was a birthday later on, whether it was an engagement or wedding. You know, so-and-so doctor is our family physician. so-and-so doctor, we just run to him when we have a problem. And similarly, the doctor himself would know, say the grandmother or the lady would come with some problems of, say, chronic headache or something like that. And he would automatically be able to tell her, Mataji, don't worry, I know your grandson is getting married, or I know your son is looking for a bride and you have a lot of tension on your head. So your headache is just due to that. You know, it gives a more comprehensive view, and very often it was the truth. This is where we have lost out. Today, somebody goes in with a simple headache. Nobody bothers to ask that child, okay, are you studying for an exam? You're spending a lot of hours in front of a computer. They start with a CT scan. They start with the highest end, this thing, almost scaring the patient into thinking they have some sort of a brain tumor, because they would have already Googled something and come. So this is the way that medicine has changed. We have a lot of technology. We have a lot of understanding, but it is being taken in the wrong direction. We've dehumanized the practice of clinical medicine to a very large extent. And this is where I feel keeping the principles of the Universal Declaration on Bioethics and Human Rights, keeping that at the forefront in our daily practice, reminding ourselves of these principles, that they need to be integrated real time, not just kept there as a poster on the wall. This is where the change has to happen.
Humanizing the interactions between.
Absolutely, absolutely.
And sir, I have another question. We tend to focus more on the technology part and running tests and doing specialized.
Yes.
I think the problem lies at the very root, that the even WHO considers health to be social, physical, and mental well-being of a person.
True.
But that definition itself would label people who have diabetes or any such disability, who have a disability which can't be cured, which requires treatment. They, according to the definition, they would be labeled unhealthy throughout their lifetime.
Exactly.
So there is a Mykirch model, I don't know if you've heard of it, which says that health should be a state of well-being emergent from the conducive interactions between a patient's potential and life's demand. And the patient's potential could be acquired or from birth. So patient's potential and life's demands with respect to the social and cultural determinants. I think this definition should be put more into action.
No, you are absolutely right, because today, in fact, even the practitioners who are looking at what we call holistic medicine, and in fact, I must share with you, due to lack of time, I didn't go into that because it wasn't, it was more of a teaser or just an introductory to narrative medicine and not really a complete workshop. Narrative medicine itself has been shown, there is research on this, which shows that hypertension, chronic diseases, diabetes, psychiatric illnesses, all of them have shown significant healing and better outcomes by just incorporating narrative medicine along with routine clinical treatment. Professor Russell has done extensive studies on use of these alternative therapies, on use of spirituality, using a patient's religious beliefs, using music. And all of these have been shown to have real-time consequences and benefits as far as healing is concerned. It's not just curing. Unfortunately, medical science, as we are taught it today, is just about curing. We are only looking, okay, let's lower the blood pressure. Let's bring the blood sugar to a particular level. And I'm not bothered. I don't really bother about changing a person's lifestyle. And that person is taking medicines. He is complaining every day that I can't enjoy my sweets. I love sweets. And he's not happy at the end of the day. He's not really healthy at the end of the day. His parameters may be what the doctor would feel like, but is he healed as a person? What about his mental state? Do we think of these aspects? So this is what we need to understand. It is not just about getting those parameters right. And today, even in textbooks, even otherwise in journals, you find there's a lot of controversy regarding just fitting patients into certain parameters. There is still controversy about what is the ideal blood pressure. So when we have not been able to come to a definite scientific conclusion or have definite evidence as to a simple, this is just one parameter. What about the entire outlook of the patient? And we've all seen that the minute we exercise, the minute we are put into a happier environment, the minute stress is removed, the body starts to heal itself. And most of our diseases today are because of our lifestyle, because of the situation that we are in, because of poor environment, because of poor food habits, because of general misuse of pesticides and a whole lot of chemicals into everything that we consume. And the minute we go back to a more simplistic lifestyle, our situation improves. So all I would like to say is, let's have an open mind. Let's have a debate. Let's have a discussion. Let's try and have holistic views of approaching our patients and not just looking at someone as parameters, as medication to be given, tests to be run, and feel very happy.
Yes, sir. Just like you said, there is people, even now, doctors think that being healthy is simply an absence of disease, which is not true. And like you said, there is no normal blood pressure, no normal temperature. It is the average blood pressure. 120/80 is the average blood pressure, and 98.65 is the average body temperature. Normal would vary person to person.
Exactly, but how many people actually are aware of this?
And I also believe that, like you said, we don't need to just cure the disease. We need to practice health in our daily life. We need to be a habit, a practice, rather than just being at an event where we just cure the disease and then we consider ourselves.
Very true, very true, very true.
That is all. Thank you for your time, sir.
Thank you, everyone. And thank you, organizers. Thank you, Professor Russell.
Thank you,
Dr. Shiv, Dr. Indy,
excellent
and Shubham also. Good to see all of you. And thank you for the opportunity for giving me a chance to present this different perspective.
Thank you so much, sir, for such an informative session on narrative inquiry. It was a great learning experience for all of us. And thank you, sir, for accepting our invitation.
Thank you.
Now I would like to invite Dr. Shubham to please take over the session.
Thank you so much, Derek sir, for that brief and elaborative session. You are amazing as always. Anusha, can you take over the session? Anusha and team there.
Yes, Shubham. All right. So before I start, I just want to thank everyone for joining. We know it's a Sunday morning in India, at least, and it's extremely difficult for everybody to get up and come for sessions like these after an extremely hectic day of work and week of work. So greetings to one and all. I'm Anusha Prabhu. I will be one of your hosts for this session. So this session is brought to you by the Scientific Committee, and it is the paper presentation. Here at Ethos 4.0, a little bit about Ethos. Over the last 4 years, we've had students from across the world who've had this keen interest in learning and studying about bioethics. And at the same time, because of this love and interest, everybody has really wanted to propagate that information to our fellow students. And that is why students have come together to conduct sessions of this kind so that we watch, we interact, and we get more information. This paper and poster presentation that we're having over the next couple of days is to tackle the research aspect of Ethos. And as we know, bioethics is very important both in the clinical field and in the research field. So without any further ado, like I said, I'm Anusha. I'll hand it over to Charlie to introduce herself.
Hello everyone, this is Shirley Valvi. I'm from 2nd MBBS LTMNC Mumbai. I'm one of the moderators today. So if you need any help or you're having a technical difficulty, please let us know. I request Ramya to introduce herself.
Hello everyone, I'm Ramya. I'm a third year student at KS Hegde Medical Academy, Mangalore. I'll be one of the moderators for today's session. As Shali said, please reach out to us if you have any technical issues, and all the best to all of you.
Yeah, Anusha, I request you to share the rules PPT.
We'll be introducing Sir first. Ramya, can you share this screen? All right. So a lot of us, I think Sir requires no introduction. I mean, when Shubham, who's our head, told us that we'll be hosting for Dr. Achyut Balur, Sir, I think all of us had jitters because we studied his books for so much of our years here in medicine. So just a little introduction about Sir. So Sir started his MBBS education in KMC Mangalore, Manipal University, and completed his MD in General Medicine there as well. He has also been the guide for numerous ICMR STS projects. He has published a list of 12 researches in national journals and 18 researches in international journals. And he's received a whole list of awards, some of which are Best Outgoing Postgraduate in General Medicine, Good Teacher Award in 2013, Dr. Patrick Pinto Memorial Best Teacher Award in 2014, Distinguished Alumni Award in 2018, Best Audiovisual Aid Award 2019, etc. So he's consistently been achieving, and there's so much that we have to learn from him. In addition to this, he's also the organizing secretary and scientific committee convener of International Cardiodiabetics Conference, Bengaluru, that was held in 2015 in September, and also the member of API DK Silver Jubilee Organizing Executive Committee. He's also worked and published a lot of books that we read today, some of which include the medicine preparatory manual that I think all of us use as a very important guide. So without any further ado, we'd like to thank you, Sir, for coming for today's session. And I'll hand it over to Shubham Gupta, who's the head of the scientific committee, to take over.
So can we see you, please, sir? I can't see you. Okay, here you are, sir. So very good morning, sir, and thank you so much for accepting this invitation, sir. It's a great privilege and opportunity for all of us. Rather, we are all undergrad and postgrad student presenting papers here, sir. And definitely you are a role model for many because we go on reading your books, sir. And I am very sure, sir, that you're going to inspire a lot to pursue medicine as a career ahead in future, sir. And I am also very much sure that all presenters are going to learn a lot from you, sir. Thank you so much, sir, for accepting this invitation. I know, sir, you're very packed and busy with your schedule. Getting you was a bit, when I approached you, sir, I was not very sure that whether I'm going to have you for a session or not, but you accepted this invitation with equal grace, sir. So that was so sweet of you, sir. Thank you so much, sir. I once again welcome you to this International Ethos Conference.
And I wish all the presenters all the best, and I think we'll begin.
Sure, sir. Anusha, you can take over.
Over to Shali for the rules and regulations. I'll share my screen.
Okay, so the rules for today are like each presentation can only have one presenter. The time allotted for each presentation will be 5 minutes up to maximum of 7 minutes. There will be dedicated 2 minutes of time for question and discussion after the presentation from the judges. Okay, and you will be asked to share your screen for the presentation. If you don't want to do it yourself, you can tell us. Please turn on your webcam so that the judges and audience, everyone can see you. Okay, thank you. I would hand over to Ramya.
So we'll just be going through the judgment criteria. The total score will be for 100. Originality and creativity will have around 20 marks. Organization, the goal should be stated clearly. This will hold 20 marks. Then the procedures, data collected adequately, and all of the statistical methods mentioned properly will hold 20 marks. And the neatness and organization, how you present, will hold 20 marks. Overall presentation, language skills will hold 20 marks. So we can continue. Over to the next.
Okay, I would like to take the attendance and make sure everyone is there. So please, can you just say yes? Akhilesh Kumar.
Yes.
Shantanu Marketkar.
Yes.
Dr. Godge Yasin.
Yes.
Dr. Himali Agrawal.
Yes.
Dr. Aditya. Dr. Himad Khulur.
Yep.
Dr. Zinal George. Dr. Zinal George.
Yes.
Sohini Chandra.
Yes.
E. Mona.
Yeah, I'm there.
Yeah, and Sharon.
Yes.
Thank you so much. I will hand over to Anusha.
Right, so without any further ado, we'll start with the first presenter. Akhilesh Kumar, can you share your screen? You have 7 minutes to present.
Can I start?
Yes, you can start.
Hello. Okay, good morning, everyone. My topic for today is case report of an anesthesia management for cesarean section of pregnant woman with idiopathic thrombocytopenic purpura. So coming to the abstract, woman with idiopathic thrombocytopenic purpura may be pregnant or the disease may occur the first time during pregnancy. Thrombocytopenia is usually noticed in the first months of pregnancy and the platelet count is often quite low. In this case report, I will be discussing about the anesthesia management for cesarean section in a pregnant woman which I encountered at 34 weeks gestation, posted for emergency LSES in view of premature rupture of membrane, who was diagnosed with ITP in the second trimester. In introduction to idiopathic thrombocytopenic purpura, it is also called as autoimmune idiopathic thrombocytopenic purpura. It's a condition in which immunoglobulin G antibodies are directed against platelet antigen, result in increased destruction of platelets. These antibodies are primarily produced in the spleen where phagocytosis by macrophages occurs. This can also occur in the liver and bone marrow. The incidence of ITP, during pregnancy is 0.01% to 0.1%. There is increased risk of induced bleeding during the peripartum period as platelet count would be lower than 50,000 per millimeter cube at the time of delivery. ITP does not affect the normal fetal development. Case report. So my case was 27-year-old pregnant woman at 34 weeks and 4 days of gestation. Gravida 2 para 0 was scheduled for an emergency cesarean section in view of premature rupture of membrane. She was diagnosed with ITP at second trimester with platelet count of 16,000 per millimeter cube. She was asymptomatic, no history of any bleeding, and had no previous history of any history or any family history. No history of any PIH or preeclampsia. Rest investigations were also within the normal limits. So for which hematological consultation was taken at second month of gestation and 4 units of platelets was transfused and then started on tablet prednisolone 30 mg TDS and slowly tapered to 20 mg OD and a platelet count was also on the rising trend. So on patient was taken on the OT table. So on examination, vitals were stable, airway assessment was normal, and no abnormalities were detected in systemic examination. Recent platelet count was 72,000 per millimeter cube, and patient was adequate anil per mouth, and returned informed consent of ASA3 was obtained. And after shifting to OT table, vital parameters were monitored. Her heart rate was 78 beats per minute, blood pressure of 126 by 78, saturation on air is 99%, and that ECG was normal sinus rhythm. 2 broad gauge IV was secured and RL was started. So she was pre-medicated with injection ondansetron 4 mg IV, injection pantoprazole 40 mg IV, and injection glycopyrrolate was given. After giving 100% oxygen for 3 minutes, patient was given anesthesia with rapid sequence intubation with injection thiopentone 250 mg IV and with oral 6.5 millimeter internal diameter cuff endotracheal tube was inserted. After giving 100 mg of injection succinate choline. Anesthesia was maintained on 50% O2 plus 50% nitrous and 1% sevoflurane with intermittent atracurine. So after delivery of the baby, we had given 100 mics of fentanyl and 20 international units of oxytocin was started in 500 ml of oral slowly. Patient was hemodynamically stable throughout the surgery. The blood loss was 1000 ml and 200 ml clear urine output was there. And intra patient received 4 units of platelet as intra platelet count was 59,000 per millimeter cube. Baby was normal with Apgar score of 10 in 1 and 5 minutes. After surgery, the neuromuscular block was reversed. Injection glycopyrrolate 0.4 milligram IV and injection neostigmine 2.5 milligram IV. And patient was extubated without any trauma or bleeding. Post-operatively, she received 4 platelet RDT and steroid prednisone 20 mg and was restarted, and the platelet count gradually improved to 81,000 on second day postpartum. Discussion regarding this case: idiopathic thrombocytic purpura, also called as autoimmune thrombocytic purpura, is an immunoglobulin G antibody directed against the platelet antigen. So these antibodies are primarily produced in the liver by phagocytosis macrophages occur. The diagnosis of ITP must be considered if there is isolated thrombocytopenia during pregnancy, where platelet count is less than 1 lakh per millimeter cube, and normal or high number of megakaryocytes are present in the bone marrow. Moreover, the blood smear often reveals presence of higher platelet volume and greater platelet diameter. So we have to rule out other conditions other than this thrombocytic purpura. There are two considerations. One is non-immunological conditions such as gestational or essential thrombocytopenia, preeclampsia, and DIC, disseminated intravascular coagulation. Immunological conditions that can be considered include a drug-induced thrombocytopenia, post-transfusion purpura, and pseudothrombocytopenia. So management of this case, conservative management is typically sufficient if ITP is diagnosed during pregnancy. Corticosteroids are administered if the platelet count is less than 20,000 to 30,000 per millimeter cube before onset of labor or less than 50,000 millimeter cube in the time of delivery. High doses of intravenous immunoglobulin G produces a rapid but transient increase in the platelet count and is administered if there is no response to corticosteroid therapy. Platelet transfusion is generally indicated in case of extremely low platelet count or in case of any acute bleeding. In severe thrombocytopenia, which is resistant to medical treatment, splenectomy may be necessary and is best performed in the second trimester. So coming to the anesthesia management, so we have to take a call regarding regional general anesthesia. The neuraxial block was not preferred in this case as platelet count was less than 80,000. As suggested by the British Committee for Standards in Hematology, recommends neuraxial block to be given if the platelet count is more than 80,000 per millimeter. Hence, general anesthesia was preferred. But there are instances where few anesthesiologists and authors have reported use of neuraxial block techniques, particularly spinal anesthesia, in a healthy asymptomatic pregnant woman with ITP, who had platelet count of more than 50,000 but less than 80,000. One such incidence is by Thoracoscopic et al. Suggested the use of thromboelastography, which may be applied at bedside. According to this, it suggests that a maximal amplitude of 3 mm in TEG means that platelet count is 54,000 and coagulation will be sufficient. But there is no relevant or any standard suggestion for using of regional anesthesia. Now, while performing general anesthesia, care must, as patient is having low platelet count, care should be taken against traumatic injury to the upper airway during endotracheal intubation as well as use of laryngoscopy. In our patient, there was no signs of any traumatic injury to the upper airways as encountered during endotracheal intubation and extubation. Post-operatively, patient was monitored for any bleeding or soakage of dressing and hematuria. Steroids was started and platelet was transfused if indicated. And these are my references: Weber, Metal, and Sigon Journal, and British Committee for Standard in Hematology and General Hematology Guidelines for Regional Anesthesia, and Chestnut Obstetric Anesthesia and Principles and Practice, 5th edition.
Nice case presentation. Was steroids given parenterally preoperatively?
No, sir. Steroids was not given parenterally as the patient was on steroid prednisolone 20 mg even on the day of surgery. Morning she had taken OD dose.
Generally, somebody who's on long-term steroids, anything more than 3 months, during the delivery or a surgery, generally it has to be converted to the parenteral equivalent, because possibly if the oral absorption and all is not this. The parenteral equivalent ideally to be given prior to surgery rather than giving the oral medications. But yes, the platelet count anything above 50,000 is ideally safe. The point here is when you say in ITP, the amount of platelets or the platelets that you see that are present in the body are generally the fresh platelets. So the chances of bleeding is less, they say. And as you said, GA is preferred because in the lumbar puncture, if there is a trauma and there is a bleeding, it would cause a little more catastrophe. That's why I think GA is preferred. The only thing is that's what pre-operatively, I think for any patient who is on long-term steroids, ideally should be given the oral dose, the injection parenteral dose, and the dose has to be hiked up to the stress levels of dose, not the normal 20 milligrams wouldn't suffice. Otherwise, pregnancy, the difference between other autoimmune diseases and lupus, and ITP, any difference regarding pregnancy you're aware of? If supposedly somebody has an SLE and pregnancy versus somebody has ITP on pregnancy.
No, SLE will be having all those skin features.
Okay, that will be the features.
And she'll be having clear history of miscarriages.
Yeah, that could be there. But in contrast to the other autoimmune diseases, SLE does not, the ITP does not improve during pregnancy. Otherwise, all of the autoimmune diseases generally have a better, they fare better during pregnancy, they improve, whereas ITP still remains the same, that the platelet count does not improve drastically. SLE improves, the patients might become much better during pregnancy due to the pregnancy hormones that are there. Any other questions from any of others?
So we are keeping discussion just to our jury panel and the presenter, sir.
Okay, then we can proceed. I think we can go to the next one. Thank you.
Thank you.
Thank you so much, Akhilesh, for that lovely presentation. Moving on to the next person, Shantanu, can you share your screen?
Yes. I'm not able to share. It's coming. You cannot start the screen share while the other participant is sharing.
Okay,
Akhilesh, can you stop screen sharing? I guess you're screen sharing.
Akhilesh, you there? Yeah.
I've started screen sharing. Is anyone able to see?
Yes.
Yeah, it is.
Should I start?
Yeah.
Okay, my name is Dr. Shantanu. I'm a third-year anesthesia resident from LTMMC Mumbai. My topic for today is anesthesia for thoracoscopic repair of right congenital diaphragmatic hernia. So CDH is basically characterized by a defect in the diaphragm that allows herniation of abdominal contents into the thoracic cavity. The incidence is about 1 in 3,000 to 5,000 births, and the most common type is usually left CDH. But what we had in this case was right CDH, a lesser common version, which happens in 13% of the cases, wherein liver and the large bowel herniates. This case is about a 25 days old female child, full-term normal vaginal delivery, 3.2 kg birth weight, who presented with a respiratory distress at birth and saturation of about 89%. She was immediately shifted to NICU and kept on O2 supplementation with nasal prongs. On investigation, as you can see in the chest X-ray, it was suggestive of herniation of liver in the right lung field and shift of mediastinum with atelectasis of right lung. On USG scan, it showed a large defect in the posterolateral parts of the right hemidiaphragm with herniation of portion of the liver. So it was diagnosed to have a right CDH, and the child was advised to have an elective surgery post-stabilization. CDH is usually associated with multiple cardiac anomalies. So a 2D echo scan was done, which was suggestive of congenital aortic heart disease, ASD and PDA with left to right shunt and moderate hypertension, pulmonary hypertension. On examination wise, the child was vitally stable. A respiratory system, however, had air entry diminished on the right mid and lower zones. The saturation pre-ductal and post-ductal both was 98 and 97% respectively on room air. The intra-op management, we did pre-medicated the child with injection atropine to prevent bradycardia. The induction was done with sevoflurane. Muscle relaxant use was injection atracurium. We use what is called as the controlled rapid sequence in intubation, in which we do gentle ventilation, keeping in check for the peak pressures, and an uncuffed 3.5 ETT was placed. Maintenance of anesthesia was done on O2 plus air plus sevoflurane plus intermittent atracurium. The analgesia we preferred was IV fentanyl and IV paracetamol. IV fluids were given as per CVP. A USG guided central line was secured after the induction, and according to the Holiday Seeger formula, in drop we managed the IV fluids. Precordial stethoscope was placed on the contralateral chest to auscultate intra-op after the drapes and everything was placed. Gentle ventilation was done with 50% of FiO2, and a warmer was used to prevent hypothermia. And the right lateral position, as you can see in the image, was given with appropriate padding on the bony prominence, and eye padding was done. The soft bolster, as you can see here, was placed underneath the thorax. So this was a thoracoscopic images. This is basically from the head end. The surgeon is standing at the head end and the scope is introduced from the cephalad end. So you are viewing this from the top view. So you can see a defect here. You can see the liver and you can see the lung. So in the first left-hand side image. On the right-hand side image, you can see the liver is being reduced by the surgeons. And in the left-hand side bottom image, you can see the defect is being sutured after the liver is being after the liver is reduced. And the last image is after the repair. So the anesthetic challenges in this case were the lateral decubitus position, the capnothorax, which is created for laparoscopy, and hypoxemia, which is associated with a pathophysiology of CDH. So in lateral decubitus position, infants have a VQ mismatch more than that of the adults due to their soft compressible ribbage, and the FRC closer to CV closing volume and airway closure occurs at tidal volume and dependent lung. So the O2 requirement is basically higher than in adults. It is 6 to 8 ml per kg per minute, whereas in adults it is 2 to 3. A soft bolster, as I showed in the previous image, was placed beneath the shoulder, beneath the thorax, and vigilant monitoring of the peak pressures was done. Capnothorax may flows were kept for 0.5 to 1 liter per minute and pressures were 4 to 6 mmHg. Higher settings lead to mediational shift and hemodynamic collapse, and the cold CO2 leads to hypothermia. All this was prevented with the monitoring of the peak pressures, and was using a warmer. Hypoxia, 25 centimeters of water was kept. Avoidance of nitrous is important as it may lead to further expansion of the gastric. And single ventilation cannot be used in this case since the affected lung is hypoplastic. In spite of all the preventions, because of these three things, the lateral position, the capnothorax, and the capnothorax, there was one episode of desaturation, which was dealt with 100% FiO2, and the surgeons were asked to stop the surgery, and transient deflation of the capnothorax was done. And after the patient stabilized and the saturation picked up, the surgery was started again. So the coordination with surgeons is equally important in these procedures. The other complications and challenges were the pulmonary hypertension. Increase in PVR leads to left to right shunt caused by acidosis, hypothermia, and increased peak pressures. So these these factors were completely always avoided and prevented perioperatively. Then there is hypotension, which can be caused due to overdistension of the stomach and herniation. And hypotension can also be caused when the hernia is reduced. After the hernia is reduced, there may be compression of the IVC, and there may be hypotension at that point. Thus, we also avoid IV line in the lower limbs for this particular reason. Pain management, as I said earlier, was given by opioids, injection fentanyl, and paracetamol IV. Caudal block in this case was avoided as the anatomy was a little bit difficult, and the caudal space was palpated very higher up, near the PSIS almost. So caudal block was best avoided in this case. And port infiltration using injection bupivacaine 0.5% was given for post-op analgesia. Otr ergonomics, however simple we think, in this particular cases, in laparoscopy cases, it becomes difficult. So everyone should know where they are placed. So as you can see in the image, the screen is at the foot end, the surgeon is standing at the head end, the assisting surgeon is on the left side, and the nurse is at the right side. Just adjoining the nurse, there is a laparoscopic instrument so that it becomes easier for her. And the anesthetist is at the right side besides the surgeon, besides his workstation. He's at a place where he is easily accessible to both the workstation and the patient. So the outcome of this patient was basically the patient was well reversed and well extubated. It was good owing to the favorable prognostic factors like pre-op respiratory condition, avoidance of acidosis, hypothermia, ventilatory-induced injury perioperatively, adequate analgesia, gentle ventilation, vigilant monitoring, and a thorough pre-op evaluation, which is necessary in every case. Apart from this, planning and a proper coordination with surgeon is necessary. As you can see during a desaturation episode, it is very essential that you coordinate with the surgeon. Thank you. These were my references. Thank you.
Patient had some amount of pulmonary hypertension. So which are the drugs that should have, which are generally avoided when you have pulmonary hypertension and anesthesia? Hello? Hello, am I audible?
Hello.
Yes, sir.
Yes, sir, we can hear you.
Yeah, this patient had pulmonary hypertension. So which are the drugs to be avoided? Anesthesia drugs to be avoided?
Actually, sir, ketamine is a drug which we use for induction. Those drugs raise ICP, the further increase in BP. Those drugs are avoided. E6 frenin are actually vasopressors which we kept reserved only for the cases where there is major hemodynamic change. So these usually we avoid. But in this case, if there was a hemodynamic collapse, we would have used it.
They didn't venture to correct those PDA at least. ASD, I think they can wait, but PDA with pulmonary hypertension, they could have corrected.
No, actually, the patient was quite stable. The PDA, they said they had waited for about 25 days. Like this patient was diagnosed on day 4 of life. They waited for 25 days for stabilization of the patient, and at day 25 they had to take a decision to electively operate this patient despite of those anomalies. So we had to take due precautions like the air bubbles and everything. Those precautions were taken, and we taken a CVP line so that excessive fluid was not given. Those precautions were taken, and we had in hand our inotropic.
For the hypoplastic lung, would it function back to normal at the end of surgery? There was any change?
Untoward if happened, we were ready for that emergency. The hypoplastic lung causes the mortality. We cannot cure the lung per se, hypoplastic lung. What we can do is cure the defect, and then we have to wait and watch and observe the child in NICU. Hopefully, the healing occurs on its own. At the most, we can give ECMO to the patient for a better healing of hypoplastic. But other than that, there is nothing actively we can do for the hypoplastic lung. The lung has to heal on its own, so there is a wait and watch after the surgery. And the child.
The child was extubated and was maintaining good saturations.
Yes, sir. Because preoperative condition was good, sir. The preoperatively also the child was maintaining 98%, 97% on air saturation, and the pre-op condition was good. So the child was maintaining with that hypoplastic lung. Also, he had survived 25 days without any complication. The child was basically asymptomatic, sir. He didn't have those classical symptoms of CDH. He only had presentation at birth. He had respiratory distress. Thank you.
The next presenter.
Yes, thank you so much for the presentation. Dr. Yasin Godke, can you share your screen?
Hello, good morning. Am I audible?
Yes.
Hello.
Yes.
Yes. Today I will be discussing about a thesis done at our hospital. I am anesthesia resident from LTMMC in Mumbai. A study of duration of post-operative analgesia with 0.2% ropivacaine for peripheral nerve blocks for upper and lower limb surgeries in pediatric patients aged 5 to 12 years. Introduction. Pain management is an important aspect of anesthetic management and becomes even more essential in children as they are more vulnerable to pain due to their limited understanding and communication abilities. there is no denying that complete pain relief heightens the morale of the children, improving the quality of anesthetic services. Good pain relief makes child comfortable and cooperative. Parental satisfaction is also achieved. In this case, patient benefits are superior analgesia, which results in calmer patients and parents, intraoperative hemodynamic stability, and obtains the hormonal stress response, reduce intraoperative blood loss, and reduce MAC, resulting in smooth emergence and earlier return of appetite. It also provides improved gastrointestinal function, that is peristalsis better maintained and improved splenic perfusion. The aim and objectives to study the duration of post-operative analgesia of 0.2% ropivacaine in pediatric patients aged 5 to 12 years, to study the duration of sensory block, and to study the duration of motor block as well. After approval from ethical committee, the study was conducted in orthopedic and plastic operation theater of our hospital. 38 pediatric patients were included in this study, and it was conducted from December 2018 to August 2020. Inclusion criteria was parents willing to give consent, ASA grade 1 and 2, age group 5 to 12 year, patient posted for upper and lower limb surgeries. Exclusion criteria were patients allergic to local anesthetic agent, patient having coagulopathies and on anticoagulation, patient with liver failure. Withdrawal criteria was put the case in this: no sensory block in the region supplied by block nurse was withdrawn from the study. Consent of the parents of children meeting inclusion and exclusion criteria was taken and NBM status was confirmed. The time from nerve block to first rescue post-operative analgesia was taken as the duration of analgesia. Time from nerve block to the return of cold sensation in block extremity was taken as the duration of sensory block. Time from the nerve block to full recovery of motor function of the block extremity was taken as the duration of motor block. And the duration of analgesia, duration of sensory blockade, and duration of motor blockade was assessed 10 minutes post-extubation and at 4, 8, 12, and 24 hours post-operatively. Sensory assessment was done in the form of touch and cold sensation with spirit. Motor blockade as considered lower extremity patient unable to move hip, knees, or toes. Upper extremity patients unable to move arm, finger, hands. Post-operative patient was monitored by using pain score. For children less than 7 years, FLSCC score was seen, and for more than 7 years, VAS score was seen. Study design is the prospective observational study. Place of the study was orthopedic and plastic operation theater in our hospital. And study population receiving peripheral nerve block with ropivacaine 0.02%, aged 5 to 12 years. Sample size came around 38. Statistical analysis was done with Microsoft Excel Windows 10. And what we got, the results, the study of total 38 patients were selected out, of which 12 were below 9 years and remaining were 26 were above 9 years of age. Upper limb was considered in 32 patients and lower limb was selected in 6 patients. And type of block, totals 18 supraclavicular blocks were given. Axillary block given to 8 patients, interscalene to 5, sciatic block was given to 3 patients, and femoral nerve block was given to 4 patients. An average duration of surgery in upper limb and lower limb were upper limb 2.2 hours, lower limb 2.5 hours. And duration of analgesia, what we got for upper limb was 11.7 hours, for lower limb 10.8 hours. Duration of sensory block, what we got from these patients, for upper limb it was 9.1 hours, for lower limb it was 9.89 hours. The duration of motor blockade, again for upper limb 4.16 hours and lower limb it was 4.28 hours. The summary and conclusion: this study was conducted in 38 patients, pediatric patients of age 5 to 12 years. undergoing either upper or lower limb surgeries in tertiary care center from December 2018 to August 2020. The primary aim was to evaluate the duration of post-operative analgesia with 0.2% ropivacaine, and secondary aim were to evaluate duration of sensory block and motor block with 0.2% ropivacaine in pediatric patient. Appropriate peripheral nerve blocks with 0.5 ml per kg of 0.2% ropivacaine was given after induction of general anesthesia. Post-operatively, patients were followed, and time from the time of nerve block to the need of first risk analgesia was noted. Duration of analgesia, duration of sensory block and motor block was noted to be, you can see on the screen, those serious adverse effects were seen or were there any signs of systemic toxicity. In conclusion, administration of 0.5 ml per kg of 0.2% ropivacaine for peripheral nerve block in 5 to 12-year-old children was found to give adequate postoperative pain relief up to 11 hours. Thank you.
Study or have studies like this been done?
Yes, sir.
Is it a novel study or do we have similar studies being done? Have you compared it with?
But it's a novel study. We haven't compared with.
There is no other study where this has been done at all in the world. Ropivacaine was used for local thing, was never done in the world.
No, it was done, but for this age group, it's only study we have produced.
So it's
with that particular blocks.
Okay. So was this
and with particular concentration?
There was an intervention that was there. Was this registered with the CTRI? This is a trial sort of thing where you're introducing a drug.
It is registered, sir.
It was a registered trial. Yes. Other drugs the children received was same. Was there a difference in other drugs that the children received, or it was the same things other than this? Was this standardized?
We had that toxic dose, and within that toxic dose, we have provided all drugs. Other mode of anesthesia was different for the children, just like induction with sevoflurane, injection if more than 7 years, if weight is more than, then we have used in some patient injection propofol, but specifically we provided only ropivacaine injection with 0.2% concentration.
You said the recovery of whatever the sensation was assessed by. How was it assessed?
We used two different scales. Before 7 years, up to 7 years, and more than 7 years. More than 7 years, we use that VAS scaling, and we also had that at particular point when the cold enter sensation are coming, using spirit ball like that, and movement at the hip joint.
Standardized thing where the spirit ball is used for temperature.
Yeah, we can use different also.
That's what. Is it a standardized thing where you use a spirit ball for temperature?
Yeah, for cold sensation we use it.
Anyway, I think there should have been comparison with other studies and what is the change in the results. Otherwise, it's a good study. Only thing, I think your PPT should have been better. Does it look like a Word document which is flowing? Anyways, thank you.
It will be a series. I will also performing for the comparison with the other sensory blockage with using different drugs. That is also in progression. We will be looking forward for it.
Thank you. Moving on to the next presenter, Dr. Imali, you can start sharing your screen.
Good morning, everyone. Is my screen visible?
No, not yet.
Is it visible now?
Yes.
Okay, can I start?
Yeah, carry on.
Okay. Good morning, everyone. My name is Dr. Himali Agarwal. I'm a resident in ophthalmology in DY Patil Hospital, Kolhapur. I would like to present a longitudinal study to evaluate eye changes following the initiation of SSRI therapy in patients with depression and anxiety. So selective serotonin reuptake inhibitors, SSRIs, are very commonly and sometimes the first line drugs which are used for depression and anxiety. Now, literature has reported some cases of mydriasis and increasing IOP, intraocular pressure, in certain cases of angle closure glaucoma. So these patients have a predisposition for angle closure, and prior examination before starting have been found to have a narrow angle. So these drugs can rarely also cause effects which are severe enough that can cause discontinuation of drugs and even permanent vision loss. And similarly, long-term SSRI treatment can also cause multiple transient vasospasms in the optic nerve, and this can lead to ischemic optic neuropathy. The common mechanism which has been accounted for is the increase in serotonin levels, which causes these vasospasms. So having said that, this provides us with an area that has been not as much explored, especially from an ophthalmic point of view, and sort of highlights the importance of an ophthalmic evaluation in before as well as during SSRI therapy. So my objectives were to observe for changes in routine ocular examination in patients who've been started on SSRIs, specifically tablet sertraline and tablet fluoxetine. The doses were administered for each patient.
Sorry to interrupt you, Dr. Himali, but your slide is not changing with the case.
Okay. Is it changing now? Are the slides changing now?
Yeah.
Okay. The objective slide is on display right now.
Yes.
Yeah.
Okay. So I will just go over the objectives once again. So this was the objectives included to observe for changes in ocular examination in patients who've been started on tablets sertraline and fluoxetine. The doses were administered for each patient, and a comparison was drawn between the ocular effects of sertraline and fluoxetine. In order to conduct the study, an incidence of 15% was taken, and a 212 participant sample size was evaluated. Out of this, 113 patients were examined, patients who dropped out, and certain patients who could not follow up with us due to corona, etc. So finally, we had a count of 113 patients. 18 to 45-year-old patients who had anxiety and depressive disorder were evaluated. They were diagnosed based on DSM-5, and from an ophthalmic point of view, a visual acuity, best corrected visual acuity, IOP measurement through tonometry, color vision assessment to rule out any prior maculopathy or toxic influence on the fundus was ruled out. Slit lamp biomicroscopy was performed in order to evaluate the angle, and fundus examination was done. These were my observations. So out of all the patients that we examined, we had 4 patients on sertraline and 3 patients on fluoxetine. Out of these, the patients with sertraline 50 mg, 3 patients showed an increase in IOP. This IOP was not significant because it still fell under the normal physiological parameter of 10 to 20 mmHg. These patients were also asymptomatic. The discontinuation of medicine and continued psychotherapy was the treatment that was given later. I would also like to point out that this IOP measurement is also subject to diurnal variation. So this is a limitation of this IOP measurement. One patient who had been complaining of eye pain and blurring of vision after starting of the drug had narrow angle before starting of the drug in a pre-treatment evaluation. His angle was found to be significantly opposed after the medication was started when he came with complaints of eye pain and blurring of vision. This patient was also given tablet sertraline 50 mg every day. The continuation of the medication was discontinued and psychotherapy was continued. The patient did not have an angle closure attack again. There were 3 patients with fluoxetine. All 3 of them were in 40 mg fluoxetine. These patients complained with blurred vision and headache, 2 of them, and had an IOP increase. And the 3rd patient complained of eye pain and had a significantly IOP increase. Now, what I would like to point out is that these 3 patients had IOP, which was slightly beyond physiological limit, which is 10 to approximately 20 to 21 mmHg. So what I would like to point out is that awareness before starting SSRIs is very important, especially from the point of a psychiatrist. Timely intervention by discontinuation of drugs is important. And these effects that we see are preventable and reversible up to a certain point of usage of the drugs. This is what I have concluded, that potential ocular risks is very important to assess before we start SSRIs. Also, patients need to be counseled that they have a predisposition for angle closure and that mydriasis itself, which is a very commonly seen effect of these drugs, can have an effect and lead to angle closure, especially in a narrow angle configuration. Ophthalmic consultation is important both during and before the treatment is started with periodic follow-ups, and ocular side effects should be carefully observed for. Now, the future prospects of this study are that various doses can be evaluated along with the side effects based on doses. Macular changes in optic nerve ischemia is something that we did not come across in our study. Probably a larger sample size will help observe these changes. Also, alternatives in narrow angle patients need to be observed, and a comparison with the other pharmacological agents based on how much incidence with each pharmacological agent is found can also be explored. Thank you.
I think it's a group effect of all the drugs belonging to the category?
No, sir. Drugs. We have other drugs. So we have actually chosen sertraline and fluoxetine because in SSRIs, paroxetine has been found to have a very frequent effect in terms of mydriasis and increased IOP, whereas there has been inconclusive evidence regarding sertraline and fluoxetine. Some studies have reported sertraline to have only 16% effect of that found with paroxetine, and of fluoxetine to have only 10% effect as compared to paroxetine, which is the most commonly studied drug amongst SSRIs for ocular effects.
Paroxetine has gone off use for maybe one of the possible causes was this. There are other side effects of paroxetine also. So some sort of a group effect, but maybe the newer ones or the other ones do not have that much of this one. There were no retinal changes at all of any sort?
No, sir. In these patients, prior to the study, hello?
Yeah.
So in these patients prior to the study, when fundus examination was done and color vision was also seen in order to observe, for macular changes, the fundus was found to be normal. In these patients, only angle changes as well as IOP increase was found. Literature has reported that it takes a longer time of duration in order to see any macular changes as well as optic ischemia. So probably my conclusion was that probably a higher dose may predispose these patients to a higher level of serotonin, which can cause vasospasms and optic ischemia, leading to ischemic optic neuropathy. So.
None of them presented with an acute attack.
So one patient presented with acute attack, sir. He had angle closure at the time of reporting.
The take-home message possibly, I think, the simple bedside evaluation where we look at the anterior chamber and see whether the anterior chamber is small.
Yes, sir, narrow. Yes, sir.
Narrow,
or shallow anterior.
Yeah, shallow anterior chamber. I think maybe in undergraduate times we do not emphasize so much of ophthalm examination. But I think a simple test that you could shine the torch and you could see the entire iris possibly very clearly from the side, then possibly it's a shallow angle or a shallow anterior chamber. And these are the patients I think where we should avoid this drug definitely, because I don't think so even giving a single or 2 doses of this can precipitate an acute attack, and that can be dangerous. So possibly I think we have to emphasize this at undergraduate level itself. Just simple clinical examination to look at the size of the anterior chamber. I think that would help in preventing a lot of it. Nice study. Thank you.
Thank you.
Thank you, Dr. Imari. Next presenter is Aditya. Please start sharing.
Hi, I'm Aditya. I'm trying to share my screen. Can anyone share my presentation if it's possible? I'm not able to share my screen. Okay, I'm able to now. Sure. Yes. Can you guys see my screen?
Yes.
Okay, cool. So we're going to look at my presentation, which is about versatile 3D printed prosthetic arm to improve activities of daily living and quality of life for below elbow amputee. So it is a single case study, and I'm Aditya. I'm an occupational therapy intern from the Department of Occupational Therapy, and I'm from the Sri Ramachandra University. Next slide. Okay, so the introduction. So below elbow amputation. So amputation has always been a part of medical conditions. So in India, last year was about 16,500 below elbow amputee cases, and every year there will be about 0.11 billion amputees in all over India, and most of the regions will be from the northern part of India. And 3D printed prosthetic arm, which I gave for this patient, was stress desistry. So this is the 3D printed prosthetic arm gave my patients. So this is from Spain, where it's a 3D printed prosthetic arm made of 3D printed material. It helps with activity of daily living, like by grasping things, something like grasping a water bottle, which I'm holding right now. So they're going to improve the activities of daily living for the patients. As an occupational therapy, I'm going to give adaptive devices like these to improve the activities of daily living. So next is occupational therapy for below elbow amputation. So here, pre-prosthetic training was started, and later than post-prosthetic training. In pre-prosthetic training, we do desensitization and improve muscle tone and muscle power for these patients, and later jump into post-prosthetic training by giving out the prosthetic arm for the patient to increase their activity of daily living and then improve their daily live activities and also in the occupational performance. Next is my aim. So my main aim was to improve and use a versatile 3D printed prosthetic arm, which is this tres desis meri. So it's a tres desis is a Spanish word for prosthetic arms, and meri is the prosthetic arm which is given for below elbow amputees here. And for below elbow amputee patients to improve activities of daily living, ADL, and quality of life. That was my main aim for this case study. So my objective was to find out the improvements in activities of daily living and quality of life, and to determine the use of prosthetic arm, this 3D printed prosthetic arm, which is stress desist meri. That was my main two objectives. So Nexus Methodology. So it was a single case experimental research design, and my sample size was single case, and the sampling method I used was convenient sampling. And my inclusion and exclusion criteria was my patient diagnosed or present with below elbow amputation. Since I'm using stress desist meri, I'm going to look out for a below elbow amputee patient. So next was the subject must understand both English and Tamil. And next is patient present without any stomach complications such as ulceration deeper than fascia. Next is exclusion criteria. Other level of upper limb amputation were excluded from this study. Next slide. So we're going to talk about the results. So these are the evaluatory tools I use for these patients after giving out and even before the prosthetic arms. I was like pre and post evaluatory tools I've used. So this is upper extremity functional status index, UEFS. So here the patient scored no difficulty of 20, and then a little bit difficulty of 24, and 6 moderate difficulty, and 1 quite a bit of difficulty, and 0 difficulty. So this is a 20-item questionnaire where the patient will be asked what kind of functional tasks that they're unable to do in their daily activities and how it's affecting their quality of life, like bunch of tasks like brushing their teeth, taking a bath, eating food, like that. So these are like a basic questionnaires, like what we do in daily living were asked. So here the patient, they mark a little bit of difficulty in 24 and no difficulty in 20 of these things. So next we're gonna see the pre and post intervention of Opus Health Quality of Life Index. So this is a health quality of life index where I use for pre and post op. So post prosthetic training and pre prosthetic training. Here, the pre prosthetic training, the patient scored a score of 66, and in post prosthetic training, the patient scored a score of 79, which is a drastic improvement compared to the pre and post. So Opus Health Quality of Life Index is more than 20 plus questionnaires. It is both physical and psychological based questionnaire since it's a quality of life. So here it's also like what are the tasks the patient will be having trouble doing in their activities of daily living, and the quality of life will be also be psychological. How often the patient feels depressed, or how often they feel sad about their condition, something like their amputation, and how often like do they go out and they feel bad for having an amputee arm. So these are the questionnaires they were asked, and the post prosthetic training score showed 79 from before, which was 66, which is a big drastic improvement. Next is the satisfaction with device and service. So the device is this prosthetic arm, and service was my intervention, occupational therapy intervention. So here the patient scored 12 in most strongly agree, and agree was 7, and neither agree or not disagree was 2. So which is a good thing for our service and our intervention. The occupational therapy was given to this patient, and disagree, strongly disagree was 0-0 for this patient because our intervention is always good. So next is the results. We already talked about the pre and post intervention about the patient and evaluatory measures we saw. So here analysis and the study revealed that versatile 3D printed prosthetic arm, which is stress resist Mary, showed significant improvement in activity of daily living and quality of life. Also, the Opus Health Quality of Life helped show that the pre-prosthetic training score was 66, and it gradually increased to 79 in the post-prosthetic training and post-intervention, I mean. And here also the final device satisfaction was evaluated using the satisfaction with device and service, showed positive results and strongly agree in most of these item questionnaires. Next is my discussion, importance of occupational therapy in upper limb amputation. Occupational therapy, the main aim is to improve the activities of daily living for the patients and improve quality of life. So that is what I did here, gave my intervention, gave this prosthetic arm for this patient so she could do her activities of daily living by herself, ADL skills. Next is the importance of prosthetic arms. So without having a prosthetic arm, it is hard to do bilateral activities, but having a prosthetic arm can help you do most of the bilateral activities more easily, and it can make them functionally independent as possible. And 3D printed prosthetic arm and quality of life, not only it improves the functional independence, but also the psychological independence, where they won't feel like they won't have an arm after amputation. Next is Opus Health Quality of Life showed strongly agree in most of the aspects, and satisfaction with devices showed that they loved the intervention of occupational therapy, and also they were satisfied with these devices. Next is my conclusion. Your versatile 3D printed prosthetic arm intervention has shown better improvements in activities of daily living and quality of life in patients with below elbow amputee. So thereby the patient ability to perform ADL skills and occupational performance, which is the girl was from the school age. So she was going to school and also do her daily task at home with this prosthetic arm now. During functional activities, also improved following occupational therapy prosthetic training. And future recommendations, I'll be including more samples for generalizing the treatment plan, and then implementing the future prosthetic research with added mechanism to the prosthetic arm, like having a 3D printed or more like a myoelectrical prosthetic arm, and also can do with a different kind of prosthetic arms, not only just 3D printed like myoelectrical or different kind of like combination of 3D printed and myoelectrical. And future project can be done with experimental and control groups also. And these are my references, and thank you.
Which has been discussed. Only thing is, I think it's a single patient. We cannot infer anything much about because it's just one patient, though all your scales and all those things to get a meaningful reference or meaningful inference, how much it has improved, etc. we would require more. Only it has to be a very large size, because this is an intervention that you're planning, an intervention that is going to improve. So all those things have to be studied on largest larger scale. And just by one patient's thing, I think we cannot infer all these things. Otherwise, it's a very, very, very good and novel intervention.
Thank you. Thank you. Also have a small clip, like a 10 seconds clip for you guys to see, and I'll play it right now for you. Thank you so much.
Thank you.
Thank you.
Thank you. Our next presenter, Himad, you can start your presentation.
Okay. Okay, so can you guys see my screen?
Yes.
All right. All right, so one second. So my paper is on doctor-patient interactions with respect to type of practice by, I'm Dr. Himal Hulur, I'm an intern, and my mentor is Dr. Aslesha Dakdekar. So let's begin. So introduction. Doctor-patient relationship is the core foundation for healing, care, and establishment of trust, and a basic foundation for medical ethics. Trust and communication forms a formidable tool in achieving patient satisfaction. However, in the last couple of decades, we have seen a rapid growth in the medical field. Patients today want to be more informed and they want to be actively involved in their own treatment. There has been a shift in how a patient is diagnosed, and a greater reliance is seen on a battery of tests like X-rays, blood tests, scans, and other investigations carried out in specialized laboratories or clinics to ensure established evidence to combat a wave of growing litigations faced by the practitioner. Any mistake made by the doctor today is judged as a failure to meet expectations of the patient and a violation of the patient's trust. In this fast-paced, resource-limited environment, doctor-patient relationship is lost. It is necessary to establish a healthy relationship, not only for the patient, but also for the doctor, because a strong doctor-patient relationship leads to a complete medical history, an accurate diagnosis, and adherence to treatment plans and better patient outcomes. So my aims and objectives were to analyze doctor-patient relationship while communicating with the patient, and also to evaluate association of problems in communicating with the patient with respect to the experience of doctors, and also to compare the duration of consultation with respect to the qualification of the doctor. So I had a sample size of 49 doctors, and it was in my own college and the surrounding area in a semi-urban area of Maharashtra. I used a pre-structured questionnaire, and the study population were medical practitioners in and around the same area. I used Microsoft Excel to analyze my data and use simple statistical tools. So let's move on to results. So doctors of different pathies were included in this study, and I'm a hello. Hello. Can you hear me?
Go ahead, we can hear you.
Yeah. So of the practitioners, about 34 were male and 15 were female. The age ranged between 22 to 67 years, and the experience was between 1 year to 46 years. And the mean experience was 15.7 with a standard deviation of 11.5 years. And when we segregate my sample size according to the type of practice, we see that the specialists, that is the MDs, were 20, the BAMS, BHMS, which I've quoted them as others, are 22, and MBBS are 7. So when we studied doctors with respect to their pathies to the total time, it was noted that the specialists spent least amount of time with their patients. So when we study history taking and clinical examination, it was seen that doctors across all the aspects of their specialties take most amount of time for history taking. It was noted that doctors from other pathies took the most amount of time in history taking, that is the BAMS and BHMS, but they spent the least amount of time in clinical examination. This was the exact opposite for the medical practitioners of specialties. They took the most amount of time in clinical examination and the least amount of time in history taking. Moving on, when we evaluate experience against total time taken, it was seen that doctors with less than 30 years of experience took lesser amount of time in all aspects of consultation, while doctors with more than 30 years of experience took significantly extra time for consultation. It was also seen that there was a large amount of variance seen in examination and time taken by doctors with lesser experience as compared to doctors with more experience. When we compare history taking with experience, we see that doctors in the age of 30 to 50 took about 5 to 10 minutes in the most. When across all practitioners, about 90% of the doctors greeted their own patients, and a close range of 45 to 75% of all doctors answered calls during the consultation, leading to an interruption in the consultation. About 75% of the doctors handed out appointments, and when the percentage of doctors who greeted their patients increased with the amount of experience the doctor gained. Less than 20% of the doctors found it difficult to confide in opposite sex of the patient. When we checked about drug schedules, we see that BAMS and BHMS spend the most amount of time explaining the drug schedules, followed by MD and then MS. So in discussion, a study evaluates the duration of consultation against the specialty and experience of the physician. The time invested for answering queries and explaining drug schedules by the specialist was the least. When we see that there were more than 30 years of experience, the time of consultation was lesser, while 11 to 20 years took a more amount of time for consultation. Greater patient satisfaction was associated with greater interview length. Senior doctors spent lesser amount of time with patients as compared to younger doctors, which was also relevant with the John G.R. Howe study. It is reported that physicians under 50 years of age had greater rate of dissatisfaction with the amount of time they spent with patients than those older than 50. Specialists spent less amount of time with patients, which contrasts with patients quoting that they had inadequate time for consultation. On conclusion, on assessing the duration of consultation with experience of the physician, more experienced consultants gave lesser amount of time to their patients. On comparing the duration of the consultation with the respective qualification of the doctor, it was noted that the specialist spent less time with the patients in all aspects of consultation. Interaction of doctors with patients was of better quality for experienced physicians compared to the lesser experienced doctors. It is necessary to sensitize doctors in their early years of practice towards good interaction with their patients. Similarly, it is important to emphasize during post-graduation the importance of better communication with their patients in order to achieve a better, complete, or a holistic healthcare approach. So these were my references, and thank you.
Study, but very relevant possibly. As you said, the specialists spending more or less time there. I think when you talk about specialists, most of them would do some procedure. Be it
Yes,
a
sir.
cardiologist, they would do an echocardiography, or a gastroenterologist would do a endoscopy. So I think that procedure also counts into the consultation time, because they would be interacting with the patient during the procedure. It's not just the consultation where they sit, speak, and examine. It's the time that they spend with the patient as a single patient. They would be doing a
Yes, sir.
procedure on the patient, be it an endoscopy or an echocardiography. I think that also counts to the time. I think that has not been taken into this, because if
Yes,
you
sir.
take in
Definitely,
that,
sir.
yeah, if you take into that, then I think they spend the most time. The time that is spent per patient would be definitely higher for the specialists rather than
Yes.
MBBS or anybody who would be less than that. And as you said, the most important thing is the explaining the medications and the procedures, whatever it is. I think that is quite lacking. And as you said, it's more in the BAMS and all those things. I think that's one thing which should be a very important thing that we have to take from here.
Yeah, sir, my study was in an outpatient setting, so I could not include the inpatient part.
Yeah, that's, I mean, quite a lot of procedures are outpatient also, but that's what the time they spend with the individual patient is a little, it's definitely more, because they do
Yes,
see
sir.
them.
Yes, definitely. Sir.
Continuity.
I 100% agree with you.
Fine. Otherwise, a very nice study and a simple study, maybe in a larger size, and you do more, possibly it will be definitely published in a very good journal.
Yes, thank you, sir.
Yeah, thank you.
Thank you, Hemant. Next, I will call Dr. Zenil George.
Is my screen visible?
Yes, yes, it is.
Good morning, all. I'm Dr. Zenil Dabre, resident in ophthalmology from GMC Nanded. My topic for presentation is clinical profile of childhood blindness in a tertiary care center. My co-author and my guide is Dr. V.M. Sahasrabudhe, who is also the professor and head of department. Vision is one of the most cherished senses. Blindness in children has unique problems and is of great concern due to its devastating implication in terms of reduced educational, recreational, and social opportunities. Childhood blindness has a far greater impact on individual and society as a whole, considering the total number of disably adjusted life years. Population-based data on prevalence of childhood blindness, which is needed to set priorities and plan strategies to reduce childhood blindness, are lacking worldwide, including from India. Hence, the study was undertaken to discern the pattern of childhood blindness in this rural area of eastern Maharashtra, as no data is available for the same. Main objectives of the study were to find out just a second. Main objectives of the study was to find out the common cause of childhood blindness and classify them, to understand age and sex relationship with blindness in children, and to identify avoidable, preventable, and curable causes. This was a prospective observational study where 250 patients were included. All patients visiting ophthalmology OPD and those referred after school health screening were examined. The study duration was 18 months. Children less than 16 years of age and with a visual acuity of less than 660 were included in the study according to the NPCP definition of blindness, whereas neonates, patients not willing to give consent, and critically ill patients, such as patients admitted in PICU, were excluded from the study. These are few images from the study population. The first image is that of iris coloboma. This patient had fundal coloboma as well, which led to decreased visual acuity. This picture is that of phthisis bulbi. This is an image of developmental cataract, where this is a reduplicate cataract along with some component of coronary cataract. This is an image showing xerophthalmia due to vitamin A deficiency. This is corneal dystrophy. To be particular, it is Rees-Buckler type of corneal dystrophy. This image shows membranous cataract. This is a case of bilateral enophthalmos, and the last year is showing characteristic leukocoria reflex. This child was diagnosed as retinoblastoma. Coming on to results. In our study, a male preponderance was found, males accounting for 65% of the study population, and the male is to female ratio was 1.84 to 1. Maximum study population belonged to the age group of 5 to 8 years. accounting for around 38%, followed by 9 to 12 years, 29%, and then 13 to 16 years, accounting for 26%. Least belong to the age group of 0 to 4 years, that is only 7%. We classified blindness based on the anatomical location involved and the etiological classification. Based on the anatomical location, whole globe causes were contributed to majority of the causes of childhood blindness, accounting for 34.4%, followed by lenticular causes, 23.60%, and then corneal causes, 20%. Based on etiology, the predisposing factors responsible for majority of the causes of childhood blindness were undetermined, that is 67.2%, and hereditary factors accounted for 15.6%. We also classified blindness on the basis of avoidable and treatable causes. Vitamin A deficiency was the most common avoidable blindness, and cataract was the most common cause of treatable blindness in this study. One more important parameter that we considered was how many parents and guardians were aware of the various rehabilitative services available for blind. In our study, it was found that majority of parents and guardians, that is 57.6%, were not aware of the rehabilitative services available for blind children. And only 19.6% of children were attending blind school. To conclude, a paradigm shift in causes of childhood blindness has been observed over years. This is probably due to development of various healthcare facilities. However, there is still a long way to reduce overall burden of childhood blindness and its implication on the individual and society as a whole. Awareness regarding various rehabilitative services, particularly in rural area, is lacking. So appropriate measures should be taken to spread awareness about the rehabilitative services. These are my references. Thank you.
Nice study and very informative. So,
thank you, sir.
Yeah, as you said, that there is a change in the pattern, the change in the causes. Possibly, I think we have to evaluate some of the social aspects of it, as well as I said, if there is any thing that could be prevented, the maternal causes or something. I think that becomes a very, very important thing. If the knowledge of the pattern of disease we know, then we can go ahead and look into those aspects. And I think quite a few could be prevented, almost all could be rehabilitated. I think that's a very nice presentation. Very good slides also. Thank you.
Thank you, sir.
Thank you, Dr. Zeenat. Next, I would like to call Sohini Chandra. Sohini, are you there?
Yes. Yeah.
You can start.
Good morning, everyone. Can you see my slides?
Yeah. Okay.
Good morning, everyone. Today I'm going to discuss about comparison of DCAP score with CURB 65 score and BAP 65 score for predicting the mortality in patients with acute exacerbation of COPD. I am myself Sohini Chandra Ganesani, third-year resident in the Department of General Medicine. I did this study under the guidance of Dr. Sushma K. Jotka ma'am, Professor of Medicine, D.Y. Patel Medical College, Hospital and Research Institute, Kolhapur. So coming to the introduction. COPD exacerbations are defined as an episodic acute worsening of respiratory symptoms, including dyspnea, cough, wheezing, and a change in the character of the sputum that result in additional therapy. The strongest single predictor of exacerbation is a history of previous exacerbations. The frequency of exacerbation increases as airflow obstruction worsens. Patients with severe or very severe airflow obstruction on an average have 1 to 3 episodes per year. It is mandatory to assess the severity of exacerbation to guide decisions regarding degree of care like home, hospital, ward, or intensive care unit, as well as intensity of treatment initiation of mechanical ventilation and follow. So in detail scores expansion, CURB 65, each risk factor scores 1 point with a maximum score of 5, in which C is confusion of new onset, U is urea more than 7 millimole per liter, R is respiratory rate more than 30 per minute or greater, and B is blood pressure of systolic less than 90 mm Hg or less than 60 to 65 mm of diastolic, and age is more than 65 years. For BAP 65 score, B is elevated blood urea nitrogen level, and A is altered mental status, P is pulse rate more than 109 per minute, and age is more than 65. So in DCAP score, D is dyspnea. According to Extended Modified Research Council, dyspnea score 5A and 5B. 5A, too breathless to leave the house, unassisted but independent in washing and not dressing. And 5B, who requires help with washing and dressing. So E is isnopenia, C is consolidation, and A is moderate or severe ischemia, F is atrial fibrillation. So in hospital mortality with DCAP score 0 to 1, low risk is 1 to 1.4%, and DCAP score 2 with intermediate risk is 5.4 to 8.4%, and DCAP score 3 or more, high risk is 21.4 to 34.7%. Mortality remains low in DCAP score 1 patients who score for pneumonia or acidemia. So aim, to do a comparative study of DCAP score with CURB 65 and BAP 65 scores for predicting the mortality in patients with acute exacerbations of COPD. So my objectives are to study all the 3 scores individually in patients with acute exacerbations of COPD, to correlate the DCAP score with CURB 65 and BAP 65 scores to predict mortality in patients with AE-COPD by comparing this. So methodology. So comparative prospective study done in D.Y. Patil Hospital, and my sample size is 118. According to the incidence of COPD in my hospital is 4% and sampling error is 5%. And my inclusion criteria is patients with acute exacerbations of COPD, both genders, patients on non-invasive ventilation. Exclusion criteria is comatose patients and patients on ventilatory support, patients with other cardiovascular, renal, and liver diseases. So the patients of acute exacerbation of COPD taken into consideration with dyspnea, chronic cough, or sputum production, and our history of exposure to risk factors of the disease. Glasgow Coma Scale and abbreviated mental score test was done initially after the admission and every 12 hourly in the ICU and at the time of shift to ward from ICU. Smoking but then cigarette pack years during duration of ICU stay, duration of ventilatory support in ICU, number of acute exacerbations of COPD in previous year, previous admissions requiring NIV, long-term oxygen therapy were taken. Investigations like blood urine nitrogen, CBC, RFT, ABG, ECG, and chest X-ray were done. So statistical analysis, categorical data was represented in the form of frequencies and proportions. Chi-square test, Fisher-Exa test were used as a test of significance for qualitative data. Continuous data was represented as mean and standard deviation. Unpaid t-test was used as a test of significance to identify the mean difference between 2 quantitative variables for comparison. So results and discussion. Mean scores among patients at variant timings. I have calculated 3 scores on admission at 24 hours, at 48 hours, at shift from ICU to ward, and the outcome of discharge and death on for DCAP score on admission is 3.36 and 4.80. At 24 hours, it's 3.49 and 4.80. At 48 hours, it's 2.89 and 4.93, and at shift from ICU to ward, it is 1.89. For CURB score on admission, it was 2.99, and discharge is 2.99, and death it is 4.15. And at 24 hours, it is 2.90 and 4.95. At 48 hours, it is 2.20 and 5. At shift from ICU to ward, it is 1.61. And for BAP score, discharge and death on admission, it is 2.91 and 3.85. At 24 hours, it is 2.87 and 4. At 48 hours, it is 2.14 and 4. At shift from ICU to ward, it is 1.53. So, ROC curve for comparison of 3 scores in patients with acute exacerbation of COPD on admission. Above ROC curve shows comparison of all 3 scores on admission predicting mortality. It shows maximum AUC for DCAP score followed by CURB and then BAP score. On admission, DCAP score found to be 80% sensitive and 80% specific in predicting mortality in comparison to CURB score and BAP score. CURB score is 80% and 54.5% respectively, and BAP score was 80% and 56.4% respectively. And at 24 hours of admission, ROC curve shows comparison of all 3 scores after 24 hours of admission predicting mortality. It shows maximum AUC for DCAP score followed by CURB and then BAP. At 24 hours of admission, DCAP score was found to be highly sensitive, 90% sensitivity, and 100% specificity in predicting mortality in comparison to CURB score, which is 80% and 77% respectively, and BAP score, it is 80% and 76% respectively. So my conclusion is to conclude that DCAP score shows promise for the risk satisfaction of patients hospitalized with acute exacerbation of COPD. ROC analysis suggests that it has good performance and is a stronger prognostic score than CURB 65 and BAP 65. Compared with CURB 65 and BAP 65, the DCAP score was a stronger predictor in both in-hospital and 30-day mortality. And in pneumonic acute exacerbation of COPD, CURB 65 had only moderate performance. The DCAP score is a simple yet effective predictor of mortality in patients hospitalized with an exacerbation of COPD and has the potential to help clinicians more accurately predict prognosis and triage place and level of care to improve outcome. So these are my references. Thank you.
I think little comparison with other studies which have done the same should have been included. The DCAP was studied and what is the thing. Maybe you should have included what is the specificity and sensitivity in those studies and what you have got. What is the disadvantage of DCAP in comparison to PERP 65?
Disadvantage, sir?
Yeah.
Sir, it is a simple prognostic tool that can be done on bedside also, sir.
Requires what? It requires consolidation to be there.
Consolidation to be there.
It requires to be having a atrial fibrillation on ECG. So these two investigations are needed, which are not needed for the other scores. Other scores, maybe you have a urea that's there, blood urea nitrogen, maybe which is routinely done. But chest X-ray as well as an ECG is not needed for the other. Others are all clinical. So this requires those two investigations that are needed. So that's why possibly the cost effectiveness of the others are this. Because all these scores, if you see the ROC curve, all these three come above that line there that you've shown. So all of them have a good predictive capacity. No doubt DCAP has more because it takes into consideration even the minor consolidation which is there. Fine. Okay. Thank you.
Thank you.
Oh, thank you, Dr. Sohini. Next, I will call Mona.
Yes. Okay, can I start now?
Yeah.
Yeah. Very good morning, respected Balu sir and one more present here. So this is Mona. I'm going to present on my study on the title Occupational Therapy Fatigue Management to Improve the Quality of Life on Cancer-Related Fatigue in Cancer Survivors. It is a single case study. So these are the overall outline of this presentation. So moving on to the introduction. So cancer is the leading cause of death worldwide. So cancer-related fatigue is very common and one of the most frequent side effects of treatment and has a deleterious effect on quality of life. So I have chosen this cancer-related fatigue. So it has a deliberate effect on the quality of life. So occupational therapy practitioners play a vital role in helping the patient to identify how each dimension directly contributes to CRF, as well as the strategies for addressing each aspect interfering with daily activity. So these are my review of literature. So Fontville showed improvements on quality of life on 20 cancer patients undergoing the treatment using FACIT-F, which is a quality of life questionnaire. So my aims and objectives are to find out the effect of occupational therapy fatigue management to improve the quality of life on CRF in cancer survivors. So my first objective to find out the fatigue levels in cancer patients. So and how it impacts on the quality of life. To find out the improvement in quality of life on CRF by providing the occupational therapy fatigue management. So this is a single case experimental design. So I have did in Sri Ramchandra Institute of Medical College. And after the screening process, a verbal consent is obtained from the patient. So this flowchart explains that the procedure of my study. So I have just first assessed for the eligibility for the cancer population. So I've screened totally 6 patients. So after that, I have excluded 5 patients due to the decline to participate, and the patients who are having mild fatigue levels, I have excluded them. So enrollment of the consent obtained. So after that, I have used for the pre-test score assessment, fatigue severity scale, and then the FACIT-F functional assessment of chronic illness therapy, fatigue. So after that, implementation of occupational therapy fatigue management for 6 sessions, and then post-test was administered, and analyze the data, and results were concluded. So these are my inclusion exclusion criteria. So the adults who aged more than or equal to 18 years, patient with cancer diagnosis, the patients who are undergoing the chemotherapy or after till 6 months, the patient score should have above 4 in fatigue severity scale, which is 0 to 3 is actually the mild fatigue levels where they can cope up themselves. So RUDAS is just for the cognitive screening purpose. So exclusion criteria, non-cancer fatigue, that includes the multiple sclerosis fatigue or any chronic fatigue, have excluded them, and taking medication directly for the relief of fatigue. So these are my 6 sessions outline. So from 1 to 6, the introduction of CRF, the general guidelines. So I have also given the fatigue diary to maintain how the levels of the fatigue they felt, and the energy conservation strategies have been implemented, and then coping strategies, the work simplification, life modification strategies, activity scheduling of their daily living, and application of the fatigue management strategies on ADL specifically. So the data analysis would be the FSS, the fatigue severity score. In the pre-test, it shows that 43, the total score, and in the post-test score, it was 32, which has been significantly reduced. And in the FACIT-F, it is a quality of life outcome measure scale. So I scored 72 in the pre-test, and the quality of life has been increased to the 96 in the post-test score. So this flowchart shows the scores in the bar diagram. And then the results of the study infers from the pre-test and post-intervention scores of fatigue, which significantly it has been reduced from 43 to 32. So, and the quality of life measure, which I used, is FACIT-F, that increases from 72 to 96. The higher the score indicates the better the quality of life. So the results reveal that occupational therapy fatigue management showed improvement in quality of life and reduces the fatigue in a single patient. So these are my recommendations. It can be done implemented in the larger populations or as well, and for a larger period. The study can be conducted for a larger group, including the various types of cancer. So the occupational therapy fatigue management can be applied for a task behavior, and we can use the Canadian occupational performance measure also to analyze their performance areas. So in conclusion, this study can be demonstrated that occupational therapy fatigue management improves the QOL by reducing their fatigue in cancer survivors. So as a researcher, I hope this study sparks interest in the field of occupational therapy to continue the research to adopt to their scope of practice. Thank you. These are my references. Thank you.
Study, and very, very important and relevant. The only thing I think, since you involved only one patient possibly, I think
yes,
you could analyze many more patients, and that would bring in more meaningful. Definitely the quality would improve. I think should continue it in a large scale, and then I think that's what is needed.
Yes, sure, sir. I'll do that. In my future, in my higher studies, I can plan to do that in a larger population. Sir. Thank you.
Thank you so much, Mona. Next, I would like to call our last participant, Sharon.
A very good morning to, or I should say rather, a very good afternoon to one and all present here. I am Sharon Glenn. I'm a third-year undergraduate medical student from Sri Muthukumaran Medical College, Hospital and Research Institute. The topic of my presentation is, don't prisoners deserve adequate healthcare? And the subtopic is, bridging the standards of healthcare between the ethical codes and the ground reality in Indian prisons. According to a 2019 government survey, India houses over 1 lakh. India houses over 5 lakh prison inmates, and that is spread across 31 open prisons. The inmate population has increased twofold over the last 2 decades and is likely to increase another twofold by the end of 2030. Indian prisons are now functioning at nearly 118% of their maximum capacity, as a result of which there is a dearth in in the resources and the space, which ultimately results in overcrowding and unsanitary conditions. Incarcerated Indians have been shown to have inordinately higher rates of illness, both physical and psychiatric illness, with communicable diseases like tuberculosis, STIs and like HIV and hepatitis, and the most relevant COVID-19 infection being the most overt and concerning. A study done on Central Indian prison inmates in 2013 showed high rates of both communicable diseases and easily preventable or curable diseases. 84% of the inmates showed signs of anemia, 18% signs of ascariasis and other parasitic infections, and that were unfortunately left untreated. 14.6% the upper and lower RTIs, and 8.7% of musculoskeletal ailments. In 2020 alone, and the central prisons in India showed 18,000 cases of COVID-19. And although the prison authorities had worked alongside the central and the state government in order to release as many prisoners as possible on bail or parole, they still sustained a total of 17 deaths in 1 year alone. A 2019 report by the National Crimes Record Bureau shows that central prisons in India are currently functioning with only half of their sanctioned medical staff. And the Indian Constitution has several. The Indian Constitution has several provisions that have been enshrined, along with ethical codes of conduct that aim at protecting the rights of these prisoners. The firstly is the Article 21's right to life, which states that everybody has the right to life and personal liberty. Although the personal liberty of the prisoners might be curbed to a certain extent, they still have the right to life and therefore they still have the right to health. And the Model Prison Manual and several landmark judgments that have been delivered over the past several years reiterate the fact and that the burden of ensuring and preserving the health of prison inmates lay on the shoulder of the state. And central prisons in India ought to be equipped with basic medical facilities like ambulance services, a pathology lab, ICU, minor OTs, and the relevant medical and paramedical staff. The Universal Declaration of Bioethics and Human Rights, particularly Article 10 on justice and equity, Article 14 on social responsibility, and Article 3 on human rights and dignity, along with the United Nations Principle for Treatment of Prisoners Code, all reiterate the fact that prisoners ought to be given access to the highest standard of available healthcare at all times. I would like to quickly draw your attention to two pertinent cases. The first one is of Stan Swamy. Stan Swamy was a tribal rights activist who was arrested in 2018 and kept under judicial custody. He was 84 years old and suffered from Parkinson's disease. His condition had worsened to such an extent where he could not even hold a glass of water that was handed to him in prison. His pleas for medical bail were quashed so many times, and he was forced to spend his last days in jail until he passed away of a cardiac arrest. The second case is of Mr. Hani Babu, who was a professor of English at the University of Delhi and a human rights activist. He had suffered from a near-fatal post-COVID-19 mucormycosis infection. He was taken from one medical center to another over a period of 3 days until finally reaching the KEM hospital, where it was shown that his infection had progressed to his eye and brain, and as a result of which he had to undergo an emergency surgery, which ultimately had costed him his vision in one eye. So what are the considerations and contributions of physicians to prison healthcare in India? It is imperative to note that access to the highest standard of available healthcare is a fundamental right as per the Indian Constitution and the Universal Declaration of Bioethics and Human Rights. Therefore, I believe it is imperative that clinics, and that hospitals and independent medical and paramedical practitioners work alongside the prison authorities and the courts of law in order to provide a healthcare facility either in-house or on an emergency basis. As healthcare providers, we carry the duty to advocate and ensure the timely reach of standard healthcare to those that might seem the most undeserving of the same, thereby preserving their basic human rights and their basic human dignity. So my answer to this question, don't prisoners deserve adequate healthcare? Yes, prisoners do deserve access to the highest available quality of healthcare at a timely and an equitable manner. It is important that physicians work with the best interest of the patient in mind and provide this standard of equitable healthcare in order to minimize their suffering and the possibility of life-threatening complications whilst providing prophylactic healthcare. All of this must be done regardless of how reprehensible their offense might be. The main goal of this is to create healthy and functioning members of society who are ready to be rehabilitated and reincorporated right back into the society where they all belong. These are my references. Thank you, sir.
What do you think is lacking? Are the doctors responsible for this?
Sir, I firstly think that there is a less awareness of the fact that there is a need for doctors in the area of prisons. And I also think that the government, and they have to incentivize it and ensure that the doctors feel safe and protected in a prison environment when they are working. So I think it goes both ways in order to ensure that they, in order to ensure that the prisoners get good quality of healthcare.
Looking at a smaller subgroup of the entire population, possibly the prisons. But if you see the entire population of India itself, the healthcare is in much more deplorable state, possibly. The number of people, you said the people who are employed in the prisons is such percentage and so much vacancy is there. I think in other places, including primary healthcare, you have still a lot of vacancies that are there. So if you look at the whole, I think it's not the problem with the doctors. It's not what we are the ones. I think everybody would want if the opportunity provided or implemented in a way. I think everyone, the doctor would be able to do it.
Yes.
Just the inclination and the possible sort of this sitting quiet and doing nothing attitude of the administration. That's what is causing this. And I don't think so.
The governing bodies and the laws along with them.
That's the only problem with this.
Yes, sir.
Though it is pertaining to us, but I think the solution for this would not be from us.
Yes, sir.
Anyways, it was a very nice discussion. Thank you.
Thank you, sir.
Thank you so much, Sharon. So this is the end, I guess. I would like to hand over to Shubham.
Okay, Sharon, amazing presentation, Sharon. And yes, something related to ethics. So definitely that is what Ethos stands for, ethics. Thank you so much, Archit Balu, sir, for gracing this occasion and giving your precious time. I am very sure that we all have learned a lot from you for today's session. And I'm really sorry for disturbing you on Sunday morning and inviting you as a judge, but I'm damn sure, sir, you also enjoyed our session, sir. Is there anything, sir, which you would like to tell to all presenters in general?
Nice session, because I think we routinely go on for only the medical part of it and maybe medical case discussions and all those things. Here it was something different, and all of them did well. And I think it's a nice forum for everybody to see and interact. And yeah, thank you for giving me this opportunity.
So we also have with us the main driving force behind the conference, Dr. Shiv Joshi, sir. He's the person why we are so much motivated and charged up for this conference. Shiv, sir, I will request you to kindly say a few words, sir.
Thank you, Shubham, and thank you, Archit, sir, for judging the session. I think it was a wonderful flow of event today, and we saw quite a lot of presentations, and each of them had a different perspective to bring in for discussion. I also really appreciate the way Dr. Archit Balur was asking and critically analyzing the presentations, the research that was presented here. It was also very heartening to see that we had a very diverse group of presenters. So we had some medical students, people coming from allied health sciences. It was really heartening to see all of us putting this effort here. So thank you everyone for participating, and let's hope we keep this up for the other events and the sessions for today, as well as for the upcoming 2 days. Thank you.
Thank you, sir. I would request everyone to please switch on their video cam so that we can have a group picture with Balu, sir. It will stay with us as a memory, because sir is very difficult to get, and I'm sure no one wants to miss this opportunity to have a picture with sir as well. I request everyone to please switch on the video cam. Are we going to make any symbol, victory or anything, or just a plain picture? Come on, guys. Sir, you should suggest us, I feel.
Shubham, it's you should suggest all of us, I think. This is a scientific. Yeah.
it's today Balu sir is going to suggest us. Sir, what should we do?
Okay.
Anything we should say. I am not so this one on that.
So we should do thumbs up maybe for all presenters.
Sure.
Anusha, you click the picture. Anusha, now you can do it, and maybe Shirley can click a screenshot.
I'm not able to. Can Ramya do it?
Yeah, Ramya, please do it. Okay, great. Thank you so much, sir. Once again, over to you, Anusha.
Shali, do you want to say something?
No, I would just like to thank everyone, the moderators and the participants, and thank you for making this event a success. And yeah.
Before we end session, I would really like to thank Anusha, Shirley, and Ramya for taking and carrying out this event so smoothly and being very cordial and cooperative with all our presenters. I hope all our presenters had a gala time presenting here, and results will be updated soon. Stay tuned for rest of our conferences. Thank you so much once again for joining in session. Dr. Balu, sir, thank you so much once again, sir, for gracing this occasion. Well done, Anusha, Shirley, Ramya. Sorry, sir.
Yeah. I think the event was scheduled till 12:30, right? So we finished early. Great.
Yes.
All right.
So paper and poster presentation. Paper and poster presentations, all events are getting finished early only, sir. I guess half an hour, maybe 20-30 minutes early, sir.
All right. Great. You also had a parallel session going on, right, on the platform?
That also concluded, sir. It concluded 50 minutes ago only. Yes, that's done.
Great. All right. Thank you, Shubham.
Thank you so much, sir.
Thank you, everyone, for joining. We hope to see the rest of you for the sessions that follow. And thank you, Shubham, for always being there to respond to our 100 messages and queries.
I love you all.
Thank you.
No issues.
Thank you to the whole team.
Yeah, you guys are my strength. You guys are my strength.